Good morning. I just want to start by asking you all to give yourselves a hand for being here. I think you being here is a testament to how important you believe that developing a thriving and healthy workforce in the Piedmont Triad is. So I just want to acknowledge your intentionality in being here. And we certainly appreciate every person who registered, who shared this event. And so I just want to, with gratitude, welcome you to the 4th Annual Healthcare Workforce Summit. We have an amazing agenda lined up for you, but I would like to just give you a little bit of context about why this initiative started, so that you can see the connectors with the individuals that are in the room with that you have networked with on today. GuilfordWorks, a local workforce development board, is a group of community leaders appointed by local elected officials and charged with planning and oversight responsibilities for workforce programs and services in their area. In North Carolina, 20 local workforce boards are responsible for the following: developing local plans for the use of Workforce Innovation and Opportunity Act funds, oversight of local service delivery systems, coordinating activities with economic development entities and employers in their local areas. Members of the local business community represent the majority of each board, and all board membership includes individuals representing business and industry, economic development, community-based organizations, education, organized labor, public assistance agencies, and more. Healthcare is a leading industry in our state and vitally important to the success of our local economy in Guilford County. We recognize the importance of your impact as well as the contributions of our labor force. Our role is to engage with employers to gain and understand the workforce development challenges and opportunities in the healthcare industry from their perspective. The GuilfordWorks Healthcare Workforce Summit is a curated platform to stimulate broader and wider strategic discussions from the healthcare industry's point of view. The itinerary will include a deep dive discussion of healthcare industry needs, in-demand skills and jobs, training, and developmental needs. We've prepared a panel of workforce experts and speakers that will respond with roadmaps for solutions. The overarching goals of this summit are to provide vital solutions to attract and retain new talent, develop and grow a thriving workforce, mitigate the costs associated with onboarding and training industry newcomers, as well as meeting the growing and increasing demands of healthcare workers in the next decade. Okay, so with that being said, I hope that you have enjoyed the partnership and networking breakfast. The food has been amazing. I want to give a huge shout out to the University of North Carolina catering team for what they've provided for us. It has been absolutely exquisite. And the hospitality has been impeccable. So we will continue to enjoy this experience. And I just want to welcome you. And without further ado, I would like to introduce you to do our opening, Dr. Carl Matacola, who is the Dean of the University of North Carolina, Greensboro School of Health and Human Sciences.
Good morning. Good morning.
Good morning.
All right, let's get it on. Welcome to UNCG Greensboro. And really, it's my pleasure, and we're very happy to host this event. And so it's wonderful to see this room full of folks, especially from diverse areas of healthcare. And I want to welcome you to our beautiful campus. And so many people that come to UNCG never have a sense of what we have hidden back here. So, exercise is good. My background is sports medicine. So, sneak on out to go down this path towards one of our music buildings at the very end. It's absolutely a great little walk. And so please enjoy the campus while you're here. I almost wore that tie today when I saw the program. I was like, I'm going to switch that up last week. Because that would look really dorky, but I think I might have the same coat on, so it is what it is. As we work to develop solutions and prepare practitioners, scholars, and advocates to meet the job needs of the region and state, I welcome you to UNCG. On our campus, we have a highly regarded School of Nursing, and if you have not seen our nursing and instructional building, if you walk out of the alumni house and keep going, about 50 yards, you can't miss it. It is unbelievably beautiful, and I'm going to comment and say it is the nursing and instructional building in that it primarily houses nursing, but it also holds all of the labs for arts and sciences, many of the labs for arts and sciences, and many of our anatomy labs for the School of Health and Human Sciences. In addition, we have some beautiful and amazing research space there. So it is, it's gorgeous. So if you get a chance and you want also to get a breath of fresh air, that's a great place to go. And we have a really exceptional nursing program, and we also have an exceptional School of Health and Human Sciences. So I'm gonna take the liberty, since we're here, to give a little highlight of some of the things that we do and how it fits into the theme of today. So the School of Health and Human Sciences at UNCG consists of 10 departments, offering undergraduate and graduate degrees, as well as graduate certificates, and those range from bachelor's to master's to PhD to ED. Our programs have common goals of improving the quality of life, promoting well-being, and advocating for underserved groups. Here's who we have: communication science and disorders and audiology, recreation therapy, recreation therapists and parks and recreation, genetic counseling. We're one of the few programs in the state that has genetic counseling. I think we were the first, and we are still the best. Gerontology, human development and family studies, kinesiology with the full range of subspecialties from athletic training / sports medicine to exercise physiology, exercise science, neuromotor, and development. And we have probably the preeminent scholars in the nation in sports psychology. Nutrition with a fully developed dietetics program, public health education, peace and conflict studies, social work, and we have a brand new bachelor's that's launching officially this fall called Human Health Sciences. And the focus of that baccalaureate degree is to help prepare health professionals that are interested in allied health professions as well as professional programs. And so we're really excited about that launch. Last year we had a soft launch with about 60 students. We probably expect anywhere between 100 to 150 students, I would hope, this fall. So that gives you sort of an overview of the programs. I like to say we have it covered from birth to aged. We have a birth to kindergarten program. We have a preschool, working preschool. We have a working speech and language and audiology clinic. And we also have gerontology. So we sort of got it covered from the little ones all the way to, when we're needing a little help before we're, chewing on a bed sheet. Got a joke like one of our friends that we always say, if we're sitting in a bed just sucking on a bed sheet, someone please, help us find something else. Often we talk about strategic planning, and I just want to give you a couple highlights of our strategic plan, which we've done this last year, just because I think it fits so neatly with what we're doing here today. Implement integrated best practice to improve support systems for students to thrive. Our goal is to prepare the next generation of students who are prepared with evidence-based practice and who are making a difference. Foster a culture of care, create an environment for personal and professional growth for all members of our community, support community engagement strategies that have demonstrable impact on the health and well-being of the community. That is today, y'all. So that piece of our strategic plan fits perfectly with what's happening here, and I'm really pleased that we can be a part of it. Let me give you another quick just overview of some of the work that's taking place in our school. We have a really strong research portfolio in our college, in our school, school and college, we use interchangeably on campus. Here's some examples. The effect of smoking status, overweight, obesity, physical inactivity with cause and cause-specific mortality risks in U.S. adults. That's one of our papers, one of the areas of focus of one of our faculty. Physical activity in colorectal cancer, cachexia prevention and mechanisms. Modeling differences in alcohol use disorder-related dysregulation of iron in the brain. That's one of our nutrition faculty. The roles of hormones on bundle-specific ACL function in the growing knee joint. I actually get that because that's sort of my background. So the ACL is the ligament in your knee. Acute exercise and hippocampal-dependent mnemonic discrimination in older adults. A functional MRI investigation. So looking at using fMRI to look at acute exercise in older adults. And so we've got several studies where we're looking at dementia, Alzheimer's, and the effects of and benefits of physical activity. Community-based intergenerational mental health for Asian American refugee communities. Our public health faculty are really, really engaged, as well as our peace and conflict studies and social work faculty in the community engaged, what we call research and service. Determine the effect of exercise and anti-cancer treatment on tumor growth and morphology, and the effect of exercise and anti-cancer treatment on tumor metabolism and inflammation. So I've teased my whole life. Lots of publications in the area of orthopedics, rehabilitation, sports medicine. That's what I do. And I would always say, you know, you get a little kudo and you go, oh, that's so great, you got that grant, you got the publication. I'm like, yeah, but I'm not curing cancer. But literally, many of our faculty are trying to advocate for better health outcomes related to cancer. So really, really proud of many of the faculty and the work that we do in our school. So pleased to have you all here. As our monitor says on our page, we like to think of the School of Health and Human Sciences as transforming the human experience. Welcome, enjoy the morning, and if there's anything we can do to support you, please let us know. Thanks.
Thank you, Dr. Kalman-Hula, and I can echo again in saying that they have been a fine host and have definitely rolled out the red carpet. As evident by this illustrious breakfast and this beautiful ambiance. I'm really excited about our next speaker on our agenda, but I would like to insert a brief thanks to our partners. And I think I would be remiss if I did not make that acknowledgement early on. I would like to thank our partners, Piedmont Alliance for Triad Healthcare, Guilford Technical Community College, the University of North Carolina at Greensboro School of Health and Human Sciences as our sponsor and host, Cone Health, Eagle Physicians, ECPI University, and Novant Health. I would like to specifically acknowledge briefly our steering committee members, Warren Crow from GTCC, Richard Payne from Eagle Physicians, Natasha Brooks from Novant Health, Dan Griggs from Cone Health, Pam McMillan from ECPI University, Suzanne Ingram from the Dean's Office of the University of North Carolina School of Health and Human Sciences, Mike Scotto from UNCG School of Health and Human Sciences, and Dr. Jeanette Wade, a Department Director for the UNCG School of Health and Human Sciences. Can we please just quickly acknowledge our steering committee for all their hard work? Now, without any more deliberation, I'd like to just introduce Dana Milliken. She is a project manager for Piedmont AHEC, Area Health Education Center, and I'm especially excited about what she's going to present today, which is a study of the Piedmont Triad's regional healthcare employer retention and recruitment landscape. This information is especially important because it is real time and it's specific to our region. So without further ado, could you please welcome Dana Milliken from Cone Health.
Thank you, Joyce.
You're very welcome.
Good morning, everyone. I'm excited to be here. Thank you for allowing me this time to speak with you about a workforce initiative that the Piedmont AHEC is a part of. And before we really dive into the initiative, I thought I would do an overview of who we are at the Piedmont Area Health Education Center for those of you that may not be familiar. So we serve 8 counties. We're actually a part of the larger North Carolina AHEC program, one of 9, and we serve 8 counties, and those are listed here above. And our mission really is to recruit, train, and retain the workforce needed for healthier North Carolina. And we do that through several services that we provide. A lot of folks are familiar with the continuing professional development service, but we also have resident and student services in our Health Careers program, healthcare education technology, practice support, library services, and our health workforce support. And so I'm going to plug our website. If you're not familiar with some of these things, please check us out. We have a lot to offer. I'm honored to be a part of the Piedmont AHEC. But we are going to focus on the workforce initiative that we have been launching since the beginning of the year. So this is probably not surprising to anyone, but there's a great need in our healthcare workforce. I'm showing a nurse workforce supply and demand chart here, but this is just one example of many across our healthcare industry. I've been talking to employers and educators. There's a need in several areas of social work, CNA, medical assistant. So this is just one example, and I want to be clear about that. But our state partners provided this projection showing from 2019 to 2033 there was the shortfall of over 12,000 RNs that we'll need and over 5,000 LPNs. And so, as you can see, there's some urgency around addressing this concern. Without intervention, we're going to continue to see that gap just widen. And so, with that in mind, the North Carolina Health Talent Alliance was formed. And really with the vision to eliminate those shortages, with the purpose of focusing on our healthcare sector. So we are aiming to create a long-term, sustainable program dedicated wholly to healthcare, and so that's the North Carolina Health Talent Alliance. I know it's a little small, but in the blue box, these are the founding partners of the North Carolina Health Talent Alliance. And so it's the NC Chamber Foundation, the NC Center on Workforce for Health, and the North Carolina AHEC program. We are also very fortunate to have supporting entities such as the North Carolina Community College System, UNCG, DPI, NCICU, DHHS, and the Department of Commerce. And so they are supporting this work and helping to get the word out and collect data, along with our association partners that you can see. So this is a statewide initiative. So across North Carolina, we are deploying the North Carolina Health Talent Alliance. However, we are taking a regional approach, which is where the AHEC program comes into play. Currently, there are 5 regional AHECs participating, but we do have the goal of onboarding all 9 regional AHECs within the year. And so, along with the Piedmont AHEC, we have Northwest, Mountain, South Piedmont, and Southeast AHEC participating. And the reason that we're taking a regional approach, I think, is evident because every region has unique needs. The makeup of your region, the availability of programs, the density of the population, all play into that. And when you have a regional structure, you can have more targeted collaboration between your local employers and educators. And so that is how we are deploying. As I was saying, we're one of 5, we're in the purple here, AHECs participating, and I'll talk about this a bit more in a moment, but we are deploying employer collaboratives in each region. So this is just the structure of how we plan to move forward with this alliance. What is unique about having a host organization is that we are dedicated resources. So I'm a dedicated resource in the Piedmont region to ensure that this alliance is convening and that will facilitate those conversations between our employers and educators. So the initiative is the North Carolina Health Talent Alliance. So we all know there's acronyms and names for everything, so I'm going to try and keep this really clear. But the initiative is the NC Health Talent Alliance, but the framework or the methodology that we're using is talent pipeline management. And so this is a U.S. chamber-created framework, or you could think of it as a standard operating procedure. But this has been used across industries, including healthcare, but in manufacturing, energy, and others, and it has been proven to really increase the quality and quantity of talent in those areas, and it provides a roadmap for addressing these shortages that we are experiencing. So in a current environment, I think we make great efforts as employers and educators to work together. But we also know that it can be quite cumbersome to manage all the various relationships that we need to. If you think about from the employer perspective, they have multiple areas that they're pulling talent from, and trying to stay in communication and manage those relationships can be cumbersome, and the same is true for our educators. They are working with potentially hundreds of employers to ensure that they're meeting while it's great that we have the relationships we do, it can be cumbersome, and the TPM structure aims to kind of reorganize the way that we work together. So if you take a look, you'll notice that the employers are now, I hit the wrong button. Let me try that again. Warren, I know you taught me. Okay, so the employers here are in a collaborative. That is one of the founding, or one of the major steps of TPM is putting employers into a collaborative for them to understand as a region, as a group, what their needs really are, and how we can better communicate that and work with our education partners to ensure that we are working on our shared need. And then the host organization in the middle, that is the Piedmont AHEC in this case. And our job is really to convene the groups of employer collaboratives and our educators and facilitate conversations of possibility and talk about how we can partner to create solutions to strengthen our talent pipelines. So TPM is made up of 6 strategies. And it's a lot easier if you just look at these kind of categories. It's a little busy. But getting organized is really kind of that first stage, and understanding who is interested in being a part of this solution or a part of this alliance, and getting employers to understand the value in working together in a collaborative. Secondly, we want to get our facts straight. We want to understand what the data says. What do we truly need? I think it's one thing to say we need more nurses, but more is not a number. So how many do we need? And getting those facts straight also help us understand what our critical needs are as a region and where employers can align. And then also bringing in our educators to say, we need to think about this together. How can we build a talent supply chain that is strong? And just a note here, our partner is the Cecil G. Shep Center for Health Services Research, or we just like to call them Shep Center. They have been the administrator of 2 major data surveys that went out, one to employers across the state. And so that survey was collecting information about what is your current workforce, what are your openings, what are your projections for the next couple of years. And I'm excited to say that we have over 1,000 facilities represented in that demand survey that is currently being aggregated and cleaned. And then the second survey is our supply side data. And so that went out to community colleges, UNCG system, private institutions, DPI. And we're asking about programs, capacity, enrollment, employment after graduation. And so Shep Center has been organizing that. They've been a great partner, and we anticipate to have that data in the next several weeks. So TPM does create clarity about our problem, and it also helps us coordinate actions on how to solve for those. And I don't expect you to read all of this, and I can make this available to anyone who's interested, but developing and training the workforce. When we have the data and we can compare employer need to educators' ability to increase pathways, do programs exist? These are the questions that we'll start to ask ourselves. And then on the employer side, what about preceptors and clinical sites? Are students available? Are students even interested? Where are our gaps? And then sustaining and retaining the workforce. Again, this falls more on employer side. What is the culture? What is the compensation? Are there services like childcare and transportation to account for that? And I want to just point out, here we go again. All right, I want to point out this note. We can't develop a way out of this situation. So we can develop talent, but if we can't retain them, we're going to end up in the same place that we are now. And so these are important questions to ask ourselves. And then lastly, how can we innovate? What are some new approaches? Are there new approaches? What have we not considered? Once we have this data, this is just dummy data. None of this is from any survey. This is just plugging in some numbers to show how this modeling could work. But if you look at what is the baseline here, if we're looking at a total application count of 592, and then actual program capacity is 336, our clinical slots are 296, we have 136 passing licensure, and then we're only employing 95. And we have some issues. It looks like a tornado because it is a tornado. And so, how can we get to a more stable pipeline that actually where people can flow through appropriately? And so this is just showing how the data can be plugged into modeling. And when we start looking at the root cause of why do we have 136 graduating but only 95 are staying employed in the area. And so just gives us some time to do that 5 whys or the root cause analysis and understand what is actually happening so that we can make some meaningful change where it's needed. So TPM looks great on paper, right? So how does it really work? Have people really done this before? And so I have a few examples up here of it, some success stories across the United States. I have had the pleasure of speaking with Tallahassee, Florida, so I'm going to just pick on them for a moment. They were able to take the data from their own area and decrease the CMA openings by 400%. That's a crazy number, but it is what they did. And that was through policy change and also reducing the time to train a CMA. Kentucky, if you have a chance to go and look up their process, they did this from a statewide level. And so they had 30 employers from across the state join a collaborative and work with educators. And they had all types of solutions. And they were able to deploy a clinical rotation scheduling platform, reduce expenses, and then also just work on the retention of nurses within their state. So I would encourage you to go and look at some of their information online. So our local collaborative. As I was saying, one of the first major steps of TPN is to organize an employer collaborative. We started this work in August of 2023, so I came on board as the project manager, went through some TPN certification, and then went straight to work from August to December of really enrolling folks into the employer collaborative. And so we hosted some information sessions, and quite a few of you were in those, and quite a few of you have continued on this journey with me, and so thank you for your support. Thank you for being here today. But we also just went through some information sessions, stakeholder connections, a work to understand who was willing to be a part of this, and created what our roadmap would be for 2024. And so we officially launched our employer collaborative in January of this year and started reaching out to our educators and letting them know this is happening here. We really want to partner with you, and hosted some information sessions for our educators as well. And then from February to about April, we've been collecting the data that I referred to earlier through the SHEP Center, and really enrolling DPI and community colleges and employers to be a part of this, because all of that information can and will drive change. And so we are waiting on that aggregated data that we can share out. The SHEP Center will make that available to the public once it's at that point, and I will be more than happy to share how to get that information. And our employer collaborative will be getting the regional data at the same time so that we can really start to talk about solutions. So who's in the collaborative? This is the list of 16 employers that have committed to this work. I'm very excited with this group and with the participation. But one thing I want to point out is the organization type here. You can see there's diversity in the facility type, and that's extremely important. I think we could easily look at the organizations and say those are all competitors, but I think we also understand that it takes all of us being strong to care for our communities. If you think about a patient journey, they go to their physician, they need surgery, so they go to the hospital. They're in the hospital for a while, and it's determined that they need to go to a skilled nursing facility. We all depend on one another. And so working together to solve this, I think, is very important, and I think it shows the willingness with this group. We have hospitals, long-term care, public health, emergency services, hospice. We have a great group that is representing all 8 counties. So what we aim to do is produce outcomes, and so data is a huge part of that. And as I have mentioned a couple of times, the supply and demand survey data will be available soon. It's currently being cleaned. And our employer collaborative is set to meet in June to really take a look at that data, determine where we want to focus. We know there's a lot of needs and we can't do everything all at once. So we have to determine what our priority is in this region, and so they'll be working towards that and evaluate what our opportunities are with our educators and really partner on those solutions. So the time frame is as soon as possible. We want to move as quickly as we can, and there are certain things that we need to have available to us to do so. And so I will be reaching out even more so to educators in the next couple of months to request your partnership in this with our employers. As I was saying, we serve 8 counties in Piedmont. So that is Alamance, Caswell, Chatham, Guilford, Orange, Montgomery, Randolph, and Rockingham. I did it without looking at it, I promise. So that is who we serve. But I know there are others here. I've talked to a couple from Forsyth County. I want to let you know that we can get you connected. If there is a TPM manager in your area. If not, I can also get you connected with others who are planning to do the same work in their region soon. And if you're in the Piedmont area, you're not a part of the collaborative, or you're an educator who wants to be involved, it is still open. We are still welcoming people. We would love to have your participation. And I'm excited to see where this goes. And so, again, if you would like to connect with anyone in your county, or if you want to connect with me directly, my information's here. I'll be here today. And enjoy, so I'll see if I can get this information to everyone that's here today. So thank you so much for your time. I'm looking forward to speaking with you all soon.
That was absolutely amazing. And Dana, thank you for sharing that information. I love that you all are so intentional, and I love learning about the talent pipeline model. I think that is something we'd love to hear more about. And there are some other models that we've looked into. I don't know if you all have heard of the sector partnership model, the next gen sector partnership model within the workforce development realm, but there are definitely some similarities, and so really excited to hear about that, and really excited about the continued conversations about that. So thank you so much for sharing the information. If you all could just please give her another hand. So now we are moving into our first panel discussion, and I'm really excited about this conversation. This is a conversation that was brought to this year's summit as a result of your feedback. Those of you who participated in last year, we did send out a survey, and there was some communication in regards to, the topic of diversity. And as you can see, and as you have heard, this is an extremely important topic. So I'm excited that we have a moderator with us today from the city of Greensboro, Maria Hicks-Pugh. She is the Chief Equity and Engagement Officer, and so we're so happy to have her. She's a guru in her own right, and just an amazing contribution to this region with regards to diversity, equity, and inclusion. And I'd like to just introduce the names of our panelists that are here, and want to invite you to go back to visit our events landing page and get information about their backgrounds as well. So we have Dr. Nakia Davis, who is a patient services manager with UNC Hospice, as well as an associate professor at UNCG, Health and Human School of Health and Human Sciences and at ECPI University. We have Dr. Jeanette Wade, who is not with us due to jury duty, but she was very instrumental in putting and masterminding this panel. So we're really honored to have her support as well as the participation on our steering committee. We have Dr. Michelle Vance, who's an assistant professor at North Carolina A&T State University. We also have Dr. Andre Lewis, who's an assistant professor and physician assistant with Atrium Health Wake Forest Baptist. And I believe she's also, as I mentioned here, an assistant professor. So we're very happy to have them. So we'll just ask the panelists to join us here up front. And if you can give them a hand as they come.
I don't need a mic, but that would be the red button, everybody. I haven't had coffee this morning. I'm sorry. There we go. Okay. Can you all hear? There we go. All right. Good morning, everybody.
Good morning.
Now you all can do a little better than that. Good morning, everybody. Good morning. There we go. There we go. I told Joyce, I said, it's not that I wanted to sit down. Wink, wink. But I find it better that when you can have a conversation with those on the panel, we can truly get to the root of everything that we need to discuss today. So I am truly, truly thrilled to host you all today. And we have a few questions that we're going to get into, and then we'll save some time definitely at the end if anyone in the audience has any questions. But what I wanted to do, I know Joyce referred us to your bios, but I've read your bios. So I wanted you guys to take just a few moments, about 2 minutes or so, and just truly introduce yourself and also tell the passion behind why you do the work that you do. And we will start with you, Dr. Vance.
Good morning. I don't think I need a mic either. So yes, I am currently a social work professor at North Carolina A&T State University. I've been in Greensboro for about 5 years. There may be a transition happening soon, but I am a social worker by trade and also education, and my focus really is around decreasing mental health disparities. So a lot of the work that I do is about improving access to care for racialized and minoritized communities, and I think what we're really here to talk about today is, at the end of the day, improving our population health outcomes for our communities. And so I'm excited to be here with my colleagues. I wish Dr. Wade could be here today, but most of the research that I do is really around suicide prevention and intervention, and again, increasing access to services and how do people access and utilize those services. And I think that all of this really goes hand in hand when we're talking about organizations and educators and researchers working together.
Good morning, I'm Dr. Nikia Davis. I am a patient service manager too for UNC Hospice. I've been a nurse for 14 years now. I also teach the LPN program at ECPI, and I recently taught my first semester with UNCG Health and Human Science, and I will be back this fall teaching that. But I love nursing in general. I love hospice because I can get to help people die with dignity. But on the other side of that, I love teaching because I am able to give my wisdom, my experience to the newer generation, and kind of lay out a platform of what we need today in the nursing healthcare world.
Hi, I am Andrea Lewis. I am a physician assistant. I've been with for about 9 years now. I also just completed my first year of teaching here at UNCG in the public health education department, and that was definitely a learning experience. I'm really excited to be here, really to also talk about diversifying healthcare, because when I went through PA school, which was at Rutgers, there was only 5 of us out of 50. So it was really a learning experience. And then also, just as a side note, And I also was the first Black valedictorian of my PA class. So I think that's
Wonderful. And you passed the mic so quickly because I was going to ask you the first question because you set it up so perfectly. But we'll go back down the road again. But why is diversity, equity, and inclusion so important in the field of healthcare? As we all know, it's a very, very hot topic in the news. You turn on the news, you get a Google alert, you get a CNN alert. Everything and everybody is talking about DEI and what to do with it or what not to do with it. So why is it still important and relevant in 2024?
So I alluded to that in my introduction, and we really have to think about how we are providing support and services to our workforce, as well as providing services and support to our communities. And what we're really seeing is, as you know, and as you mentioned with DEI, really trying to move away from performative to really action-based, solution-based, equitable work. And I think my colleagues will be able to speak from some of their other experiences. But if we can increase representation in a way that people can define their own safety in workforces as well as in their outcomes. And so I really wanted to just challenge everybody here to think about looking up some work around cultural competency and taking challenges to move away from cultural competency because it's very others-based, and think about cultural responsiveness and cultural safety. And what does that look like? And I know we can't talk about that today, but I wanted to leave that with you all because that really sets up the work that we have to do as ourselves and as the organizations and institutions that we are a part of.
And Dr. Vance,
yes.
Denzel always said in the movie Philadelphia, everybody knows Philadelphia, right? Yeah. Treat me like I'm a 5-year-old. What did you mean by those two terms?
Okay. So when we talk about cultural competency, right, we talk about how do we relate and how do we work with diverse others, and I'm using none of that in quote, right? Like how do we actually learn about other people's cultures? Cultural responsiveness is more about how do we respond and the things that we're doing, and it's about providing care in a way that is unique and that is culturally impactful and sensitive to the people that we're working with. Cultural safety is more of a newer term that's part of the continuum, and that really is about critical consciousness raising. So we have to do a lot of self-reflection and recognize the power dynamics between our providers and our patients, as well as leadership and our providers. And people get to define that for themselves, and we have to really do a lot of work around deconstructing dominant ideologies and how we've been socialized in the system.
And just to piggyback, culture sensitivity is one of the topics I teach my nursing students every term. How can we be sensitive to each other's culture? And just working in hospice in general, we know there's a stereotype around hospice. Some communities feel like when hospice is coming in, we're going to give the medications that's going to end the life, which is not necessarily true. And being at UNC Hospice, I am the only nurse of color. I am the only nurse of color, the only nurse leader. And some of my background is of higher education than the other staff around me. So there are so many barriers that I have to face when I walk into the room. But when I go into these people's home or these patients' home, they're actually able to see there's someone here that I can relate to. They understand the biases I have about hospice, so she can give us the education we need to have a smoother transition to the end of life.
Also, to piggyback on that, I think it's really important to have DEI or diversity in your healthcare workforce because it brings in a range of perspectives, and that can go to helping solve certain problems. And so one of the aspects I really like to think about is how that helps reduce health disparities. And so when your workforce reflects the community that you serve and they're part of that community, it's going to be really helpful for patients. So if I tell my patient that they need to, maybe lose weight or go exercise, they can just go to the park and go exercise, and they're like, well, I ain't got no park, in my community. Or if just walk around your neighborhood And they're like, well, we don't have sidewalks. Like, and so I can then work with them or work on my own or work with other researchers to establish targeted interventions that will help, maybe think of some other ways that I can get them to exercise and move about.
Wonderful. Okay. So it's one word that we left out. And I know many of us heard this term, but we may not practice it as much as we need to. And it touched on what the three of you all just said. It's belonging. And belonging is defined as an affinity for a place or a situation. And I'm that person that needs to go deeper. So I said, well, some might say what affinity means. And affinity is defined as a liking. So a liking for a place or situation. Do you think in healthcare there is a sense of belonging, especially for those, I see heads shaking already, so those that are served and underrepresented, or those who are trying to get hired into the workplace?
I'm going to speak from a community perspective there, just because I recently finished some focus groups with primarily Black youth and adults around accessing mental health care. And a lot of the stories that was told to me were very, very, it was a very stark for us to sit and really think about the experiences that people are having. And I'm going to say, to answer your question, no. I believe that belonging is also tied to people feeling that they can be in a space where they can trust and in a space where they're not receiving harm. And in many of our healthcare systems, unfortunately, racialized and minoritized communities, and then we think about other youth and other adults who have other intersections of identities, so we need to think about gender identity and gender expression. We don't want to leave that out when we're talking about DEI work. And I believe that we have a lot of work to do because we're continuing to harm. And so that does impact belonging, and that means that we need to have more people in the space, as Dr. Andrea said, in terms of representation and feeling that people really understand and have that empathy because of their lived experience. And that's important to think about.
I do not feel like we have a sense of belonging for many reasons. One, because we have people that have unconscious biases. They stereotype and judge individuals before they even meet them. But even more than that, when you go into an environment where you don't feel like you belong, you feel powerless. And I feel like we need to give people their power back, because when we feel like we have power, then we're able to walk in our calling and what we're there to do for that facility. We are able to embrace and give our creative ideas and bring our perspective. And we will walk in rooms not with a sense of feeling like we need to belong or we need to be, it has to be centered around us. We will actually hold our head up and feel like, I belong here. I'm walking with my head high, and I'm going to create my space and put in this atmosphere what I was here to do.
And does that belonging go back to the fact of what you said earlier, seeing more people like yourself and also working with people in a diverse background and making sure we're recruiting diverse backgrounds of people?
Yes, we need to, not just people of color, but other genders, males, Black males, males in general we need to include them more. We also just need to accept that everybody's perspective is not going to be the same. If all of us was to go taste wine together today, it may be sweet to you, bitter to you, dry to me, but does that take away from our perspective and what we can contribute to the organization? No.
Absolutely.
To speak on that point too, and also your question, for the sense of belonging and sense of seeing yourself where you work, if I don't see somebody that looks like me, I might feel like, well, I'm not supposed to be here because there's no one that looks like me. How do I know that I belong here? So I really think it's important that we do diversify healthcare and we do have people of different ethnicities, different genders, so that people can see themselves in those people. And so that's really important. I didn't see myself even in, it starts back at school. I didn't even see myself in my school. I didn't have any educators who were people of color. There was no Black woman that educated me in undergrad or even in PA school.
And the next question tackles how we get them there. This whole topic of what we're saying with belonging and DEI. What are those barriers that you all have seen to achieving diverse workplaces or diverse schooling as you are concerned, to make sure we get the right people educated? What are those barriers that you all have encountered, or that you can even speak to, even if you haven't encountered them?
I think both my colleagues, you all talked about this, and I think this is important that we bring up. Like, we do talk a lot about the education system, and I believe that there's a lot of support and more support coming depending on regions and where we're from, and really supporting diverse students through pipelines to get them into the workforce. But I think where we may be struggling is organizational culture, and some of the things and the support that we're offering for diverse professionals in the workforce. That's not my experience or my area, because I've primarily been in community work and education. But from one of the experiences that people have been sharing with me is that we need to think about, again, it goes back to what I started around cultural safety and representation and being supported, is also acknowledging the power dynamics and making sure that when we are bringing people into the workforce that we have support and we have places for diverse providers and professionals to feel safe and supported. And I think that they can probably share a little bit more about some of their lived experience in the workforce.
If I could speak to that, I think also there should be like this mentorship program. So so it's good to have this pipeline, but also just this mentorship that someone can mentor these young individuals, and that could be a way of retaining people, such as that, Dana spoke about how can we retain, how can we keep people here? Like, we can build those connections. Like, I just imagine how much more powerful could I be if I had a mentor?
And I take that along with my education. I absolutely love teaching. So when I'm at ECPI, I give them my experiences. I try to teach them opposite of how I was taught in my program. But I also just try to lay the foundation and meet my students where they're at, so that they can take that into their next career. But as a manager, when I'm bringing in workforce, I try to meet everybody where they're at, and I give them a good onboarding experience. If they have that onboarding experience and feel safe with me, then there's a higher chance of them staying to work for me. So I just think that we can break down those barriers with communication, mutual respect, understanding, and having direct conversations, not talking to people like they're here and you're here, but having those direct conversations and being open and honest. Transparency is what it's really all about.
And one of the key things that we try to do for the city of Greensboro, which some of my coworkers in the room know because I recruit them quite often, right, Fred? You have something to do for me this week, don't you, Fred? Thank you very much. But we have employee resource groups. We have 13 of them at the city of Greensboro that range from young professionals to LGBTQ+, and I'm trying to think of all their names. They have their names, but they have the names they created. Connection. We have our African American Network. We just have a gamut to make sure that we have what we need for that belonging. So I guess my thing is, we were talking about DEI and how DEI is progressing and also being pulled back. So it takes money to fund these programs. Not a lot sometimes, because I had no budget when I started out 10 years ago. But, we made it do what we did. And my question now is, how do we get CEO or that chief office, whatever that person is, and the C-suite buy-in for these programs?
I think we need to hold them accountable. I think we need to have to set clear goals and then put their feet to the fire and hold them accountable. Like you said, you're going to do this. Well, I need to see it. It's not been done. Or what are the steps that you're doing? So that's what I would suggest for us to do.
And I agree. And I think where that gap is when we think about proximity, right? If you all are the providers, if you're seeing you have staff that work with you as a leader, you're seeing communities, right? You all are more on the front lines, and I think we have to really think about those gaps between the people that are making the policies and the programs and who are implementing them. And that is really going to take a lot of work in terms of and questioning our policies and our programs. Are there things that we are doing that are perpetuating inequity throughout our organization, and then how is that impacting the community? And I believe it means that they need to listen more to the folks that are in those spaces. And talking with both of you women earlier, I think it's important that we acknowledge that a lot of the times you've been in situations that you've not felt listened to, that you've not felt valued, that you've not felt respected, and that is really, really important to the work. It's not easy for us to talk about those things, but as, you know, women of color being in specific spaces, that's what we see. And as we're educating our students, right, we have to talk about those things. So I think CEOs have to really see what is happening and how that is really coming out in the outcomes, because it's being shown in so many different areas of why we need this in a space, which if we talk about the policies, why people want to get rid of it, right?
I would just say also accountability. I'm having communication. Like, don't back off. Stand firm. Know what you're meaning and mean what you say. And if this is what we're saying we're moving forward to, then we need to stand 10 toes down on business. You know, like, be serious about it.
And sometimes it's frightening because we're all here to do jobs, some of us doing multiple jobs, and it's very difficult to say we need this program because we need a mentoring program to get that pipeline, to have that shared experience. We need these programs so people can see each other and talk about things, just as though you all did at the table talking about these things. That's what employee resource groups do throughout the year. That's why I'm a huge proponent of them. But it's a little scary. And I will be fully transparent and honest. What I had to make the decision, because I am a member of the Society of Human Resources Management, or SHRM, and our CEO, Johnny Taylor, put out there some great facts about a year ago that I took heed to 6 months ago. It's not just, like you all said, about the DEI and B space. It's about how we can truly engage the workforce. So that's where the title change came from for me, because it's not just about the equity space. It's about making sure you engage the employees, you engage the students, and that will create that space of belonging. But you have to come up with the programs where people aren't feeling threatened, and also people aren't feeling like, what about me? So with that being said, what is the most difficult, and I know you all have been there, part of implementing a DEI program? And Dr. Pettis, I'm going to start with you because you got that look on your face that you are just ready to speak. But is it startup or is it sustainment? Which one of the S's would you say? Startup or sustainment?
I'm going to say sustainment because they're so easy to jump on board.
Absolutely.
But then when they see the work that's needed, they don't stay in it for the long haul. And it becomes very tiresome because you are giving 1,000% and you're contributing in every way you know how, but then you're only maybe recognized for the 5%. And it's just disheartening because it goes back so many places, even just last week, you know, when you have state come in and you're saying, I've been doing this for 9 years and we need this, this, and this in place, and you're told, no, you don't need that, and no, I don't think that, and then you have to come back and tell in front of everybody, I owe Dr. Nicola an apology. We do have to implement this. Now, what is your plan of correction? What is the IOP process going to be? So now I'm going to have to write all of this, but I'm okay because now you recognize what I'm actually bringing to the table is going to be fruitful and helping the organization move forward.
Now, I know you have something to say.
No, I think Dr. Lee said it very well.
What about from an academic perspective, like you just said? What about the students coming out of school and just making sure that what they might have studied or what they may expect, because, you know, not saying what generation I am, but it is a very active generation right now, those of us over 50. And we need to just remember that those coming into the workplace who are in their 20s expect more and expect more from us as far as DEI. So can you address it from that perspective?
Yeah, so I think one of the key things is really preparing my students for the real world. And I think that could be a part, again, of mentorship. So not just, you know, supporting them, but also preparing them for what they may encounter when what they may experience.
No, I agree. I think that accountability piece is important. And I kind of keep going back to this because it is a sustainability issue. It's work, and people are going to come to the table with ideas that are going to sound like very scary and risky. And now, it's above my pay grade. The dean sitting over there. But I think that, there's going to be ideas that are scary and that are risky. And from a corporation or an organizational standpoint, policies drive kind of what we do. And I think it's really important that as the new generations come in, they are going to come in fast. They're going to come in hard. They're going to challenge you. We teach them how to advocate. They go out and advocate, and we don't like how they're advocating. I've seen that in an educational perspective. They're doing things very, very differently. And I think we have to be open to acknowledge that they're going to address things differently than we do. And there's value in that. And with the mentorship, we can help them get it across the finish line. But those of us that have been doing this work for a while, it hasn't been working the way that we've been doing it. So we do need to be open to holding folks accountable and doing things that might push us past our comfort zone. And that is acknowledging sometimes where our biases come in and how we've been trained to do and to think and all of that.
Now, as we wind down our questions, then I'm going to turn it over to the audience to ask any questions. If you could leave everyone with one word that we have not used, okay, to express how you feel about the DEI space and where we're headed or where you hope we would head, what would that be? I'm sorry.
You said one word? You can hyphen it if you need to. One word. Or anyone that has their word.
Life-saving.
And why?
Again, I started with outcomes and community outcomes. We are losing people in the community and we're losing people in the workforce because of the issues related to discrimination, not being inclusive, not feeling like people are belonging, stress associated with racism, gender discrimination is life-saving.
I would say my one word would be embrace. Embrace the differences of other. Embrace what other can bring to the organization. Embrace us just because we're people. Like, we're all human. We all are here for a purpose. We all have something that we can contribute. So embrace.
I don't know, could you perhaps reword your question? I want to hear you.
If there is a word that you could leave with them on, with all the troubles and everything we see in the news, like we said before, about DEI, what word comes to your heart to leave as an inspiration for the audience that you think would really, really take us there?
That's not going to be work, but it's like preface, like to do the work.
That's okay. That's okay.
Yeah, just to do the work, stay in it because it is needed, especially with those who are trying to get rid of it. But if you're here and you're in the healthcare, you know that it's needed. You know that this is something that is important for our patient outcomes, for our patients, for the workforce. So just work. Keep working. Work. All
right, Rihanna. We don't have a background music. There's no license for it. No, but it's amazing that you say that, and I don't know if you pulled it from down deep within, but do we have any Other Voices graduates in the room? Do you all know about the Other Voices program with the Chamber of Commerce? They have an amazing program that if you don't have someone specified to do the DEI work in your agency, you can at least have them go through this program annually and get them the toolkits that they need in order to kind of move your organization forward. And those of us who are graduates of the program, the one thing that we always say, believe it or not, is we are now committed to do the work. So that was a good word. That's why I said I will take it. And the one thing that I say as a DEI practitioner to kind of leave with you all before we open it up for questions is the one word that I always say, and I just said this on last Friday to our new employee orientation class. I tell them, I am like that fly at the barbecue that never goes away when there's good food and you're just swatting it, or that gnat that's in there with a fresh, stack of bananas in the house, and you're like, where did that gnat come from? It's just so annoying. That's what I'm trying to be, but annoying in a good way. We start out by being in new employee orientation. We catch them day one. We are in all of our training tracks. We look at every job posting before it gets posted to make sure that in our affirmative action plan that we have, that it is listed and properly vetted to make sure that we are doing good faith effort recruiting. So you have to be that fly or that gnat when it comes to the DEI work. Is it annoying? Yes. Is it something that you want to swat and kill? Maybe yes. But sometimes if you think about it, the gnat and the fly are some of the smartest people because they figure out how to get their work and their needs done in a smart and a sleuthful way. So that's me. Don't remember me as a gnat or a fly, please don't. But remember the takeaway of you've got to make sure that your organization respects one another. That's my word. Because you don't have to like me, you don't have to go out to dinner with me, you don't have to even love me. But as long as you respect me and respect the work that we're trying to do, we will progress. So with that being said, are there any questions of our lovely first panelists?
I would like to ask a question. I'm Mika. I'm from Cone Health. And my question is because I know this work is daunting. I was in a role for NCNA as president, had to bring forth a racial reckoning statement. And it's not always what's said, and sometimes what is not said. So in doing this work, as you said, it's life-saving. And you said, what was your word, Nikita? Embrace it. And you said work, and you said respect. How do you fuel yourself and refill your cup when you're in this spot and you're like taking all of this and you have to continue to step up and stand up in those 10 toes down?
I would say my community. So building mentorship, connections with others who are in that space with me, so that when I do have a hard day, I'm texting Dr. Wade, like, girl, let me tell you what happened today. Like, it's just having that community, or even calling my mom, like, mommy, like, I know, like, guess what happened? And so getting that encouragement to just continue to do the work, that's my word for the day. All right, and just getting that, encouragement and just realizing that this is not the first time that somebody has gone through it. It might not be the last. But again, having just that mentorship, that community that I can rely on to talk about things that are going on.
I would say for me is I am headstrong with exercising. I used to be 220 pounds. So how I come back is I go to work out. And a part of that just came from, before I was even discussed, my husband was an engineer. My late husband was an engineer. And part of the stressor that contributed to his hypertension and ultimately his passing away was the stress on his job. And I took from that, and I'm taking it with me now, that everything I do is, one, in remembrance of him, and two, that I will not let the atmosphere of work do to me what it does to him. Because my kids need me, this community needs me, my nursing student needs me, my hospice patient needs me, so I'm going to go work out even after this. I'm going to work out.
I think you both brought up a really good point. And, for some of us that are called, or whatever you want to say, that is leading efforts and constantly focusing equity and diversity, it is heavy. And people often ask me in my work, like, you talk about race every single day. You talk about intersectionality every single day. And I realize in a lot of spaces, my family, my friends, and some of my colleagues don't have to. But I would like to encourage you all to remember that we aren't the only ones that need to be doing this work. And I would want you to think about the identities of folks in your agencies and the intersection of identities for people that are, having to fight a lot of battles all the time, not just for their community and for their employees, but for themselves. And I think that self-care is important, but I want us to push us past self-care because that's pretty individualistic. And how do we care for each other better as a community? And I think that that's really important. It would be easier for some of us with privilege to walk away from this work. And that makes it sometimes even harder because I have lots of different levels of privilege, but I can't because it's my responsibility to do this work and to be there and to stand alongside folks that have to fight in a lot of different ways. And I think we have to just acknowledge that people that do this work, like that's what you do every single day for the city of Greensboro. It's heavy. And how can people support you and carry the mic and the torch for you sometimes? Because it's not just your burden to bear.
Thank you. And it is very, it is very heavy, and thank you so much. That was an excellent question. And the one thing that I do, I'm the opposite of what you all are teaching. I know you all think I'm crazy because this is just as crazy. My getaway is I've been teaching political science at North Carolina A&T for over 20 years. So I teach politics to totally get my head. I know you're like, what? But seeing those students and seeing, what the future is like, that is my juge and my wusa to kind of get away from the day-to-day of this. But the thing is, I still infuse it when I'm in my classroom, so I still can't get away from it. But it is heavy. We do need allies, and that's why we diversify at the City of Greensboro as much as possible. Our programs, our leaders, our committees, what we need to do, because it cannot be just someone who looks like me and sounds like me to do the work. Your favorite word of the day. So thank you for that question. I think we have time for maybe one more. There's one more. One more. Hello.
Hello, my name is Christina Davis. I am actually a student here at UNCG for the Bryan School. But I do have a question for the educators. So I'm looking to obviously join the workforce very soon, but I do find that it is hard to build mentorship or find mentorship or even peers who struggle with the same things that you're struggling with or that I'm expecting to walk into when I join the workforce. So my question would be, how would you set up the space for your students to be able to come to you about their questions and concerns about mentoring the workforce?
I set up that space because when I walk in, Dr. Nakia is playful. I'm going to be myself. I don't go into the classroom setting and write my nursing license on the board, 239145. I just walk in as an individual off the street, and I'm here to meet you where you are. So, for instance, last semester with my first semester with observation for HHS, I made sure to get those students into home health. And with them going to home, they were able to network and build and have people there to say, I want to share, I want to mentor you. I want you to be able to reach out with me if you have any questions. I made sure to invite speakers in that could meet them where they were at. And they were able to go to their nurse practitioner practice and build that connection. So I think it's about us using our resources to pour you in and have somebody that can gravitate to you and take you to the next level. I don't have to do that, but I feel like if I have those connections, it's my duty and I owe it to you to give you the best that you can get as you enter into the world.
For me, I just tell my students that I'm here, and it's really hard for me to say no to students. So like anytime I meet like a student who is a minority student who's like, well, I want to be a PA, I'm like, well, okay, let's do it, let's talk, but I think it really also boils down to the point that I am now here and I'm able to be that role model for students, which goes back to the how do we diversify healthcare. It's based on recruitment practices, and luckily Dean Medical will hire me. So I am, I'm here and I'm able to be that for students. That's my way of establishing this kind of mentorship place where I talk to them. Like, they don't even have to be my advisee. I'm going to check in on them because I want them to also feel like they belong, here at UNCG, and then also they have potential in this healthcare realm. So my advice for you, I'm not sure of the faculty makeup in the Bryan School of Business, but to reach out to someone that hopefully looks like you to get that kind of mentorship that you may need.
Or
parking lot, come to me. I don't know. We'll figure something out. PA, business, we'll figure it out.
And I think that question just lets folks in the room know that we have students that are matriculating out of these educational institutions here in our area, and we need to make sure that we do have apprenticeship and internships and supports, and you all have to come out from your organizations and come into our educational institutions and know that these, I call them my babies, these babies are looking for support. And so I think it's a duty from educators, from the educational standpoint, but also from the organizations and the hospital systems to know that we have to start creating that mentorship before they even get out. And if you're talking about retention, and that's important, we have to think about that. And I think she was a prime example of that. They need support.
I have one last point I want to make. I think building on to Dr. McKay, what you were saying is you have these outside relationships with your home health providers. I think it's important for organizations to form these partnerships with us, with A&T, which is an HBCU, with UNCG, that's a minority-serving institutions. Like, our people are here. You want to diversify your healthcare? It's right here. Like, it's in your backyard. I think with the Piedmont AHEC with Dana, she established this program, and I think Piedmont AHEC is doing some incredible work. Like, I stalked their website with their Piedmont scholars. I think Gabrielle may be here too. I've talked with her as well. But you guys have partnerships though with like UNC Chapel Hill and Elon. But like, where's your partnership with us, with UNCG? Where's your partnership with North Carolina A&T? Like, I want to be that for you guys. So hopefully we can talk a little bit more after this.
Wonderful. Thank you so much. And just one thing, last thing from an HR perspective, for the young lady that just said that, utilize your career services department because they will have employers that you always don't have to get a paid internship with. You can actually utilize them and or LinkedIn and find someone that you can match up with, and that could turn into a mentoring relationship. One of my students did that, and they went off to law school just fine. So with that being said, we thank you all. If we could give these ladies a round of applause. And we thank you all so very much. And belonging in the forefront of your mind. Thank you.
And if you'll just stay where you are for a quick picture. Oh, picture to the left, picture to the left. And so, awesome panel, awesome discussion. I hope everyone in the room has been inspired by this discussion. I am proud to say that we are on schedule. We are actually still on schedule. We are now going to start our break, and we will come back from our break and start with our next speaker, Dr. Lindsay Draper, at 10:35, and we will introduce her and continue on with our agenda. So you are welcome to partake in more of our food. During the north hallway are our restrooms, and also please continue to network. nourishment that our UNCG catering host has provided. So we are very excited to resume our programming. We had a wonderful conversation, dialogue with our diversity and equity and healthcare panelist and moderator. And we are excited to welcome our next speaker, who will be speaking on artificial intelligence and the future of healthcare. We would like to welcome Dr. Lindsay Draper, who is the Director of Faculty Credentialing, Compliance, Special Initiatives, and Artificial Intelligence and Virtual Reality Integration from the University of North Carolina at Greensboro. Can you please give her a warm welcome?
Hello. Thank you for having me today. It's a pleasure to be here. I am so excited to have the privilege of speaking to you today about artificial intelligence and the future of healthcare. This is a big passion of mine. I teach healthcare informatics at the School of Nursing and also have the opportunity to lead technology innovations within the School of Nursing, including artificial intelligence and virtual reality. So this is going to be a bit of a whirlwind. There's a lot of content to back into about 20 to 30 minutes. We will first take an overview of what AI in healthcare looks like, the importance of how we can use this in improving healthcare outcomes, and most importantly today, how it can be used for workforce development. So I want you to take just a minute and think about what comes to mind when you think about the word artificial intelligence. You might think about robots. You might think about computers. You might think about robots taking over the world. You may also think about the little chat bots that you interact with online. Or there was once this Steven Spielberg movie from 2001 about AI, where the little boy was trained to kind of gain emotions to see if a robot could act like a person. While AI is all of those things, it is so much more. So when we talk about artificial intelligence and AI, and you'll hear me use those terms intertwined, it's essentially training a machine with an algorithm so that it can do things that humans do. So you actually use AI in almost every day of your life, I would imagine. If you have a phone and you text and it pops up those words that you may want to use next, that's AI. If you're driving down the road and your GPS says, hey, there's a crash ahead, do you want to change your direction? That's AI. Do you have Netflix? And because you watched one thing, now you have a whole list of things to watch this weekend? Also AI. So I'm going to tell you a little bit about the timeline of AI. This is not going to be a comprehensive view. Us doing so would take us probably all week. But this is just a highlight. So while AI is a hot topic today, it is not a new concept. It isn't. The concept of AI has actually been around since the 1950s. The term AI was coined in 1956. There was a professional organization for AI developed in the 80s. And then fast forward to 2021, AI in the healthcare market was actually valued at $11 billion. Now that was 3 years ago. So we're going to fast forward a little bit today to 2024. AI can produce things much faster than humans can. It's really transforming our healthcare, and it's been shown to improve patient outcomes by 45%. Next year, thinking about the future, it's predicted that AI may manage 85% of customer interactions in healthcare. Fast forward 90 more years from now, the AI healthcare market is projected to be worth $187 billion. So, again, not an all-inclusive list by any means, but there's a couple of key takeaways. One, AI is not new. Two, AI has definitely immersed itself in healthcare. And three, the AI healthcare market is rapidly expanding. So how is AI being used in healthcare? We're going to talk more about this in the next few slides. But up here, you can see that AI is being used to help do things like CTs and X-rays. We also have the Da Vinci robot that's being used to perform surgery. This cute little friend up here is Moxie. This is a robot used in healthcare. Yes, I did just say that, a robot in healthcare. It can deliver supplies. It can that can blink, that can make mad faces, that can make sad faces. But what you may not realize is this is also AI. Now, this doesn't look like a real person. So how is this being used? Coaching, mentoring, telehealth. There's all of this potential to where you can have an AI model that looks like a human. So to dig a little bit more into this, AI applications in healthcare for diagnostics and imaging. For that AI-assisted diagnosing and medical imaging with CTs and X-rays. Early detection of diseases. You can use algorithms to analyze retinal images that can detect signs of diabetic retinopathy. Personalized treatment that can offer precision medicine to tailored treatment plans towards our patients. Pharmacogenetics and AI to predict drug responses, so we can actually predict adverse events to drugs based off of the patient's genetic profile. Virtual health assistants. We have those fun little chat bots that you can ask questions to. It can also be used for telemedicine. Predictive analytics, AI algorithms to forecast disease outbreaks. So predicting the spread of infectious diseases based off of population data and environmental factors. Hello, COVID. Predictive modeling to identify high-risk patients for proactive interventions. How can we identify the patients that we can proactively engage with to prevent further health diseases? We're also seeing lots of applications being specific to nursing that can be used in other realms as well. So workflow optimization, enabling documentation and administrative tasks. So that voice to text where you can say what you want to say and it types it out for you. Scheduling appointments and resource allocations. So we can optimize staffing levels based on patient acuity and workload. Patient monitoring with remote sensors and wearables, so that we can pick up on patients' vital signs from afar. Real-time alerts for patient conditions, so that we can interact if a patient's health is declining. And decision support. So the AI clinical decision supports for evidence-based practice, providing treatment recommendations based on patient data and clinical guidelines. But also integration of AI tools into nursing education and other healthcare education, which we're going to talk about in a few minutes. So to address why we're all here today, how can I be used for healthcare workforce development? Well, first is that education and training piece. So we can integrate AI topics into healthcare curricula, teaching students about how AI is used and how to use it ethically and responsibly. We can also use it for simulation training, and we're going to circle back around to this in a few minutes as well. So here at UNCG School of Nursing, we are using AI in almost every day of our lives to do things like automate administrative tasks, to generate emails, content and idea generation, providing student feedback. And again, this list could go on and on and on. But one in particular I want to point out is virtual reality. So if you're not familiar with virtual reality, essentially you put on this headset and you are immersed in this virtual environment in a way that feels real. You feel like you are there. So we implemented this last fall in all of our BSN and nurse practitioner programs. We used it for simulation and class activities. It's a great way to get students engaged in the classroom. but also for some clinical replacement for our undergraduates as well. Now, there's a couple of things I want to point out for virtual reality. It has endless possibilities, in particular related to interdisciplinary collaboration. So with these headsets, it removes the geographical barriers so that we can have disciplines working together without having to be in the same building. Mind-blowing. Now, outside of the classroom, we've tried to use VR as much as we can. So we've had Science Everywhere, where we have Guilford County students come through, and we let them see what virtual reality is all about. What is it like being a healthcare provider? We've had the UNCG Health Fair. So we educated students on campus about meditation. And they were able to be in a virtual environment with leaves falling. And even though they were in the middle of campus, they were in their own little world, learning how this technology can be good for our mental self as well. And then professional development. So while we offer virtual reality to our students in classrooms and simulations, we have a number of students that come to us and say, can I practice? So this is a great remediation tool as well. Now, virtual reality is a fun way to learn, but it's also important to consider the outcomes as well. One way to do this within nursing is to assess how it relates to our NCLEX competencies. All of our scenarios for virtual reality are aligned with those NCLEX competencies. And so we can see from the fall to the spring how our students increase competence in all of the NCLEX domains. Now, what does this mean? We have better prepared nurses in the workforce. It can also be used to measure improvement over time. So repetition is key to learning and for students to really engage that competence and confidence in their practice. So here you can see the first time they engaged in scenarios, maybe it was the score. They repeated the scenarios a few times and their score increased. Now this is Christy Davis-Collins, our pre-licensure program director, watching that improvement in scores go up. Which again, translates to nurses that are prepared for the workforce. We can also use AI for skill development. So continuous professional development of AI-powered tools. So platforms that can really personalize learning based off of the user's performance and preferences and areas of needing improvement. Training programs on how to use AI data analysis. So we can offer sessions and workshops on how to use these AI-powered tools and software to analyze medical data that can be used to make informed decisions. We can use AI-powered platforms for acquiring new skills. So online platforms with algorithms can be used to recommend personalized learning paths based off of the user's current experience and career goals, enabling users to acquire these skills at their own pace. So it goes back to meeting the individual where they are. Reskilling and upskilling. I'm not sure if you're familiar with those terms, but reskilling means that we teach someone a skill to help them do something different. So how that translates to healthcare would be taking a nurse from the bedside and how do we give them the skills to then work in telehealth or in the remote monitoring area. So that would be reskilling. Upskilling would be how do we give someone the tools to do something elevated beyond what they're doing today. So for instance, how can we train individuals on genomic medicine so that we can have AI do the administrative routine tasks that frees up the individual to then do something more at their level of competence. We can also use AI to match skills to job opportunities. So using AI-driven talent management platforms to match skills and qualifications and preferences with available job positions. Now, this can really be used to streamline recruitment processes and ensure optimal resource workforce allocations as well. We can also use it to predict the future workforce needs. So we can model, forecast demands based on population demographics, off of trends, technological advancements, and then anticipate where those shortages or surpluses may be, and then plan accordingly. And going back to that coaching and mentoring, so we can actually use AI to analyze communication patterns and then provide that personalized feedback on leadership skills and clinical competencies and interdisciplinary collaboration. We can also use it for collaborative care models. So interdisciplinary teamwork facilitated by AI technology, so platforms that enable various professions to work together to share patient information, to enhance communication and coordination amongst all professionals. We can do that by prioritizing urgent messages and flagging, hey, this is really related to PT, or this is related to nursing, or whatever that may be for the situation. And then leveraging AI to improve patient outcomes through coordinated care. Now, these benefits don't come without some challenges that we need to consider as we embrace AI, one of which is data privacy. So we have to ensure that the data is handled in a way that respects the rights in individuals. Algorithmic bias. This goes back to what we talked about earlier. If AI is built on an algorithm, and the algorithm is biased, then the output will be biased. So we have to make sure that we're considering those biases when these platforms are being built. Now, what's really interesting that I've started using a lot lately, you can use AI, such as ChatGPT, to help you identify those biases that you may not be aware of. So, for instance, you could copy and paste a series of texts and say, can you help me to identify where the bias may be? And that's another tool that we can use to help us be aware of those biases that we may not be aware of. Transparency, so understanding how the AI decision making happens, what the results mean, where it came from, how those algorithms were developed in the first place. Accountability. So because AI is not a person, AI is not accountable if something goes wrong. So we have to be aware of that as organizations, if we employ AI, that at the end of the day, we're responsible for the outcome. So take, for instance, a customer call center. If it's an AI customer call center that directs someone in the wrong way, at the end of the day, it's not AI who's held accountable, it's the organization. Which is where trust comes into play. So the willingness to trust and accept and believe that AI is being used in the right way and being helpful. There's also regulations to consider. So the U.S. Department of Health and Human Services actually sets guidelines for the use of AI in healthcare, including workforce development, to really ensure that the AI tools and trainings that we have meet certain standards for safety, efficiency, efficacy, and fairness. There are adoption disparities that we need to consider. So uneven distribution of AI adoption across different regions, sectors is a real thing. For instance, larger companies might be more likely to deploy AI than smaller companies. Inclusion, so proactively involving and representing those diverse attributes in the AI system. So another example, if you have a language translation model, not just using the common languages, but making sure that it can translate for all languages. Fairness and equity, so ensuring that AI training tools are accessible and beneficial to all healthcare professionals, regardless of background or location. And then misuse of technology. So this is the inappropriate application of AI technology. One of the biggest examples of this is over-relying on technology. So that over-reliance on AI to make decisions instead of the human. Which brings me to my next point. A lot of people ask, are we going to be taken over and be replaced by AI? And And the answer is no, not right now. And here's why. So we're going to see some shifts in what the human does and what the technology and computer can do, but it can't replace humans. So AI lacks the ability to make something new. So it's given these algorithms, and it only knows what we tell it to know. So it can't put these pieces together and create something new. Only a human can do that. AI lacks the ability to understand the context of the situation, the ethics, the moral principles that are really integrated into what we call wisdom. Now, AI in healthcare can really help to improve outcomes, but it cannot replace the human in decision making. It really lacks the emotional intelligence, and it doesn't have the ability to handle those complex and unique cases. It cannot replace empathy, which is crucial in healthcare. Now, humans and machines can both excel differently and in the same space together. But again, AI cannot replace human. And at the end of the day, the human has to have the ability to override what the AI says, because it's our wisdom and our empathy and our connection with patients in the community. So perhaps you're not sold on the whole idea of intelligence being artificial. I get it. Another way to look at this is like thinking of AI in the mirror. So you have AI and the mirror vision is IA, which is intelligence augmentation. So intelligence augmentation is really looking at AI as a tool to say how can we augment our human intelligence and what we can do to promote collaboration and improve efficiency rather than replace the human. So again, lots to consider with workforce development. There is a huge potential growth for AI jobs. Okay, so AI engineers, AI project managers, there's a whole realm of things that we need to consider about what we need to put in place to make AI where it needs to be. Impact on traditional employment structures. So what I mean by that is shifting those human jobs to things that require that leadership, critical thinking, and let AI do the things that we don't need to do. The things that can be automatic, generated, routine, kind of admin tasks. The importance of human oversight cannot be stressed enough to really ensure ethical decision-making, accountability, and mitigate risks. Complementary roles of AI and human workforce. So AI can assist people, thereby freeing people up to do those higher-level tasks that we mentioned. Lifelong learning opportunities. So AI-powered platforms can offer continuous access to educational resources, personalized recommendations, and opportunities for skill development. We have to adapt to these technological changes through AI-supported training. So we need to invest in the upskilling of the workforce, offering training programs that teach employees how to work collaboratively with AI that's both ethically and responsibly, how to use it to analyze complex data sets, and how to make informed decisions. We also must invest in workforce development and new training programs, again, that upskilling and reskilling. So as we navigate this rapidly evolving landscape of healthcare, it's really clear that the integration of AI holds immense potential to revolutionize the way we deliver care. However, with great potential comes great responsibility. So today I present a little miniature call to action to help us kind of roadmap those steps that we need to take to harness the power of AI in healthcare. So first, we need continued research to really understand the applications in healthcare, to really define those patient outcomes, and to not only explore the possibilities of AI, but its abilities to address these complex changes in the healthcare system and the healthcare workforce. Secondly, we must innovate. So we must foster an environment that encourages the development and acceptance of new AI tools tailored to meet the individual needs of our healthcare, our patients, and our community. By nurturing this innovation, we can unlock the full potential of AI. And finally, but perhaps most importantly, since we're all here today, is to prioritize workforce development. So it's crucial for healthcare workers to be equipped with the knowledge and skills needed to thrive in an AI-enabled environment. This requires comprehensive training and really ensuring that our workforce is prepared to leverage AI. So AI is here to stay, whether you like it or not. So we need to come together to find a way to embrace it in a manner that is ethical, responsible, and can improve efficiency. So together, let us embark on this journey towards an AI-enabled healthcare where the potential for transformation knows no boundaries. Thank you. We have time for questions? Okay. Yes.
So we've seen the rollout of AI in the restaurant industry, in transportation industries, with the cars that are self-driving, the waitresses that come to the table to bring food. What's the rollout on nurses as robotics? I mean, is that on the drawing board? Because of the shortages that we have in the industry?
Yeah.
Just a question.
No, that's a great
Thoughts?
point. That is the Moxie robot that's being used in healthcare. So right now it's mainly being used for those, the tasks that humans can't do. So it can fetch supplies, it can sit there and be your sitter and talk with patients that are confused. So again, it frees up that labor constraint to say, hey, this is something that technology could do. It can also be used for patient education. Again, keeping in mind that it has to be trained with an algorithm that knows how to train the patient safely. But things like routine discharge, the robots can do that and do it pretty well. Now, can it hang medicine? No, not yet. Would we want it to? Probably not. Just knowing the issues that we have with technology today and like with the machine dispensing system, it's a user error of is the right medication loaded into the system. So to have a robot loaded into the system and then administer it to a patient, there's a lot of room for error. But it has been used by healthcare organizations in those kind of like main tasks, like education and communication and retrieval skills. Now the other side of that is cost. So the facilities that are using these robots are like the big systems in California that have lots of financial resources. But there is an opportunity there to act collaboratively as to how we can engage in some of these technologies together and have the purchasing power to get them a little cheaper. But there's huge potential in the future. This is an area that you want to keep an eye on. Like, you think it's pretty insane today, wait till next year. Wait till tomorrow. It's changing that fast. Any other questions? We have time for one more. Yes.
Hi. I am in home care. How would that translate into home care services?
That's a good question. I think a lot of the translation there would be how can you use it for remote monitoring and education and chatbots so that it can address some of those healthcare concerns before the nurse actually has to come out to the patient's home. That's one realm in which we're already using it. I think you're going to see it used more so in the future. Particularly with the sensors and wearables, all of the technology pieces that can send what's happening with the patient clinically directly to that provider. and then having those patient portals to where the patient can then interact with, you know, their provider, or ask questions, and get that real-time feedback, and, you know, not have to call the nurse and say, I have a question about, you know, this is happening, what do I do? You can use AI to then direct them in that direction without having to engage the nurse. Now, eventually, if their question is not answered and it's a little too complex, it will eventually be rerouted back to the nurse.
So we have this shortage with nurses in healthcare. You know, nurses is who goes out and in our cases with our cars and stuff. So is there any way that to translate to help offset that?
There is always potential. They even have drones now that will deliver stuff. I don't know if you've seen it, but I don't think it's broken into the space of home health yet. But even things like drones delivering supplies or delivering stuff to patients' homes, it's in the future. Amazon's already using drones. So I'm sure Amazon for healthcare is too. Another thing just worth kind of exploring on the topic of technology is Apple. So when you think of Apple, you think of, like, it used to be computers and now it's phones. Apple is taking a stance that they will be the number one in healthcare. Let that sink in. So with that comes new innovations and new ways of how we do things. Because you're right, it is the time where we have to embrace these technologies to help with the workforce. And it takes the algorithmic power to know how to program them, to do it responsibly and effectively, and to make sure that we're helping outcomes and not harming them, which also includes finances. So there's a price behind doing this as well. But we've got to keep pushing. Okay. Thank you all. Thank you, Dr. Lindsay Draper, for that amazing information. I believe the takeaway is, how might we continue this discussion with artificial intelligence or intelligence augmentation, AI or IA. So that was incredible. So we are ready for our next panel discussion. I'm very, very excited about this discussion. This panel discussion is entitled Building Bridges and Strategic Collaborations. And we are excited to have our moderator for the day, who is Natasha Brooks, Talent Acquisition and Campus Recruiter with Novant Health. And our panelists that are joining us for today are Brandon Cisco, Director of Talent Development at Action Greensboro, as well as Dan Grigg, Workforce Development Manager, Cone Health, Dr. Hussein Khalili, who is the Senior Associate Dean in Academic Administration with Winston-Salem State University, and Shamika Shuford, who is the Manager of Inclusion and Pipeline Programs at Novant Health. So we are very glad to receive a very diverse, well-rounded group of panelists to join us for today. So can we ask them to come up, but also welcome them to the front.
Wow, great afternoon, everyone. So nice to see the room. When it was a gorgeous day, the rain held off for us, so it's amazing. To my wonderful panelists, I'm privileged to have worked with each of you except for Brandon, so it's nice to meet you, and perhaps we'll collaborate afterwards. Getting started, almost like a movie trailer, like the little reel that wants to embrace you to go see the movie. Kind of give us a snapshot beyond your title of who you are. And we'll start with you, Shamika. Can you guys hear me?
Yes.
Okay, perfect.
Again, I'm Shanika Shuford, Manager of Inclusion and Pipeline Programs at Novant Health. And I have a privilege on a daily basis to impact the lives of students, starting with high school students and transitioning through students who are pursuing their healthcare degrees. So I support a team that manages internship programs that welcomes high school students, but we also manage unpaid internship programs in which we welcome students of all ages, and finally scholarship programs in which we provide upward mobility opportunities to team members at Novant Health. Thank you.
Thank you. Good morning, early afternoon. So, same holiday. So I'm here from Winston-Salem State University. I'm the Senior Associate Dean for the School of Health Sciences. At the school, we have 11 different programs, from nursing, for sure, the Bachelor LPN, to go to the DNP programs. Also OT, occupational therapy, PT, physical therapy. We have TR. Yes, okay. And can everyone hear me well? Sorry if I was lower. And also a number of other programs, social works. I don't want to miss anyone, so we're very pleased and grateful to having all different programs there. And prior to joining WSSU, I was in the University of Wisconsin-Madison, and prior to that, I was in Canada. So my journey mainly has been in nursing as my professional background. Also, I've been part of interprofessional education and collaborative practice, or interdisciplinary, as been mentioned. Past and ended up being part of an interprofessional global initiatives as well that we call Interprofessional Research Global. I'm happy now to go to I will share what we have done through Interprofessional Research Global related to BDI, related to healthcare development, and a number of other initiatives. So again, thanks to Natasha for inviting me to be part of the panel, but great things.
Thank you.
Hey everyone, I'm Dan Grigg with Cone Health. I always get a little bit nervous when we get up here, so I apologize. But so I guess the trailer version of my life is all things tuition reimbursement is a big passion of mine. So one of our projects we're working on internally at Cone Health is to kind of restructure that program to help all folks, because not everyone can be reimbursed, right? So build an internship program. For better or worse, we have a high school pilot starting with GCS this summer, so we're really proud of that. Working with some folks that are going to talk a little bit more about apprenticeships later, so that's going to be coming into our world. But essentially, my job is just to reconnect with our community, especially after the COVID-19 pandemic, and just let folks know that we're here to work with them and help them grow. Nice to meet you all.
Thank you, Dan. I'm going to share up front. We are partners, actually, Greensboro, with many folks in this room. We are especially good partners with Cone Health and their internship program. So I just want to give you a shout out and say thank you for that. My name is Braylon Frisco. I am the Director of Talent Development for Action Greensboro. Action Greensboro is a nonprofit economic development organization based here in Greensboro and Guilford County. My personal background is before that, I worked right here at this fine institution in the business school and then came out of the consulting world before that. Our work involves attracting and retaining talent right here in North Carolina, and particularly in Guilford County. So we like to think that we are adding value to attract talent and retain it here through our programs. Our programs include our Campus Greensboro program, which is an internship fellow program that is running. Proud to say this summer we will have close to 170 interns coming into our cohort program working with our partners. And then we run Synergy Young Professionals Organization. So that's sort of that second step. Once somebody has decided they want to make Guilford County their home and grow themselves and their career here, we want them to have a place that they connect. So Synergy, our young professional organization, does that. And then sort of the last talent program we run, you may have seen this, is a program called Boomerang. And that is where we are actively going out and recruiting folks who are from this area, and we market directly to them wherever they are. And we tell them that you grew up and so did Greensboro. And we have brought back in the last 2 years about 200 folks who are coming back to bring their talent here. So all things talent, attraction, development, retention, we sit in that space and work with a lot of folks in the community. So thank you for having me.
Yes, thank you. For me, I feel like I have the best job that, as a woman of faith, I feel like the Lord tailor-made for me. I have an education background. I was a special education teacher for 12 years, and then I transitioned to I'm the director of the After School and Summer Enrichment Programs at Mount Zion Baptist Church, then to High Point University in the Office of Student Success as a department administrator and then success coach, and now as a campus recruiter. So I get to go to college campuses all through North Carolina, Maryland, PA, you name it, and meet with career advisors as well as deans and professors and most importantly students, and then have those intimate conversations and bring them together. So I'm so grateful. Thank you, Joyce, wherever she may be, for this opportunity to be here. Before we get into our questions, I just would like to know what made you say yes, not to the dress, but yes to accepting the invitation to be present, especially given the magnitude of your workload and how busy you may be. Why are you here?
That's a wonderful question. I'm here because you invited me. One of the things I'll share is that I always tell people that I am a product of wonderful career and technical education programs. So programs that took students who came from areas that were rural and exposed them to opportunity. And day to day, I have an opportunity at Novant Health to lead innovative programs. And for 17 and a half years, which is what I did not share with you, I spent a majority of my career in public education. And most recently as a career and technical education director in New Hanover County Schools. And what I was met with was situations where employers did not know how to engage students, which means we had a gap in that pipeline. So today I took the invitation to come and share more about the programs that we have developed at Novant Health and how they will prove to be beneficial and to address, local economic thrusts.
Thank you.
Great questions for sure. So I'm here for knowledge networking for sure. I'm still new to North Carolina and really want to learn more as my position is senior associate dean, working with all different programs in the health-related professions, and healthcare development is a bigger issue for myself, and also I've been engaged in many different venues to make sure that we have the right people at the right time for the right people. So I think that's very essential for myself to be here and also share some of my thought and my work experience through my career over 20 years. And then the other piece that I really acknowledge is about the gap that we still have between enrollment to graduation and then getting into the workplace and sustaining, retaining them and helping to grow. Hopefully, as we go to the conversation, we can share and we can learn more.
I also accepted because I was invited. I'm really passionate. For those of you that don't know me, I came from 10 years of higher education experience, working as a career counselor both at North Carolina A&T as well as GTCC, and it's really important for us to kind of re-engage students, not just at the college level, but the high school level below, to let them know that healthcare is a good career, that it's desperately needed. And I'd like to be the person here that is going through the trials and tribulations of making workforce development effective at a place like Home Health. So if anyone would like to talk to me afterwards about some of the challenges that I'm going through to try to make some programming, start moving forward, I'd love to talk with you. So.
Well, unlike the others, I just forced my way on this panel. Joyce, thank you for the invite. I love emerging talent. I know that sounds crazy, but the work to work with the folks in our community, the emerging talent that's being developed here, is amazing. And I will brag all day long. I heard it earlier. Where are our local partnerships? What are the things we're doing with the talent that's coming right out of this county and this area? Some folks know this, others don't. There are 50,000 college students enrolled in Guilford County every year. Part of our work that we do at Action Greensboro is to really do some hyper-local surveying of employers and working directly with employers about their needs, about the things that they're hiring for, where they're hiring, how they do it. There are 50,000 college students here studying in all sorts of areas. Last year in our survey, less than 50% of our local employers are recruiting on the campuses that are right here. So that is something that I am a huge believer in. It is something that we should bring onto these campuses and connect that talent. And I love to talk about it and brag on the talent that sits here and help folks connect with them as much as they'd like to.
since you have the mic, this kind of leads into partly what my question was, which was, or is, how can educational institutions collaborate to address the specific healthcare workforce needs of the community? So when you're dealing with that partnership.
Well, I can't really speak for the education. While we are partnered with all of the local universities, Action Greensboro is a nonprofit. We sit off campus. So we work, I love to call our work translation. So we sit between that survey with employers and really getting to know what employers are looking for, what are those transferable skills that are missing on their campuses, who are they looking to hire, and then we like to work in translation. So to take all of that information and share it with our educational institutions, share it with our apprentice programs, share it with our Guilford County school system, and so that we can further address the need for those skills and identify exactly what they are. I often feel like this conversation takes really high level, and we need to be talking about those skills that employers need and how do we introduce that to students. So I like to call it translation, and we sit in the space where we try to make every effort to help our partners on both sides make that connection.
Sorry, Jen, but we're going to do ladies first for the moment, just for the moment. So, Shamika, my question to you is, how do healthcare employers attract and retain talent in a competitive labor market?
One of the things I'll share is that you have to be innovative. Having worked with students in a K-12 system, I know that seems to be a moving target. With all of the innovation that you just heard, listening to all of the impact of AI and what is happening in our society, we have to begin to meet students where they are. And so, one of the words that I like to use is you have to be able to pivot. And I'll call out some of our other TA teams and the work that they do. She shared that she's in our talent acquisition department, and she travels to colleges throughout the nation to go to these career centers and talk to students, help them feel comfortable about things that they fear. So these are some strategies that we must use. Another thing that we have to continue to do is to open our doors. I shared in my introduction that often employers could not figure out the formula of how we bring our high school students in. You have thousands of seniors graduating right in your back door every year. So how do you gain data on really what their career interests are? How many of your students are going to remain in your communities? The only way that you're going to know that is if you design and develop strategic programs. And within Novant Health, we have a program that we developed called Bridges to Healthcare. Our program targets students in 11th through 12th grade. We do target underrepresented minorities because these are the individuals that will remain in your communities often. But not just that, there are also individuals who do not have the support at home and the understanding of what some potential career opportunities are. So we open our doors, we bring them in to an 8 to 12 week internship program. We pay them $17 an hour, and we expose them to so many different modalities within Novant Health. Now, our main goal is, of course, to fill business critical roles, right? But we know that sometimes we'll find students who we are impacting their knowledge base so that they can make informed decisions about their future, and that's just as important. I could go on and on, but I will give someone else an opportunity.
Thank you. Dan, I'm going to pivot to you. So what opportunities exist for cross-sector collaboration between healthcare and employers and other industries to support workforce development initiatives?
That was one of the hard questions. Again, the next panel is probably going to discuss that a little bit more, but it's really important for us to challenge our biggest assumptions as we decide on programming and being unique and targeted as we move forward. Innovation comes from looking at other sectors. So, for example, I was told a year and a half ago when I started that apprenticeships aren't a possibility in healthcare, and Davidson-Davie Community College has proven that's not true. So, looking at what other systems are doing, TPM is a great example with talent pipeline management. It was Foster that began in manufacturing, and now we're taking that model and applying it to healthcare. So, I think it's really important for us to all come together because we have ideas that we can share with other industry. I had a great conversation with Lincoln Financial Group, for example. They have nothing to do with healthcare, but the gentleman that I met with really took the time over an hour to talk to me about the benefits of their apprenticeship program. But more importantly, as a new employee, new workforce development initiative here at Cone, he kind of summarized some of the challenges
tips on how I can kind of get this bureaucracy to kind of open their eyes and see that we have to be more innovative, because we do. We're not going to survive if we don't as an industry.
Thank you. Dr. Khalili, how can healthcare education programs leverage partnerships with local healthcare facilities to enhance hands-on learning experiences for students?
Great question. So maybe I can start with the bigger picture and then get into the more details. So we know in higher education and health related as well, you have four major issues, from access to education, higher education, to affordability, to equity, as well as success. So the local community will be very essential in every component of each of these items. You brought a very important piece. For example, if you look at the data from age 25 and below, only 34% of those populations getting their bachelor's degree and higher. If you look at the higher degree graduate, only 14%. This is based on North Carolina. So from 90% of age 25 and under, so 90% get high school diploma, 34% bachelor's degree, and then only 14% go to the graduate and professional program. And health education and health career are mainly need professional students and professionals. So again, in that way, so we have a great group of people that we can attract, recruit them, and bring them to the education in order to address the shortage in healthcare. Because as was mentioned in early in the morning, so only if you look at nursing, we have huge deficit, let's say, just in this region. If you look nationally, much higher. And then we want to train more nurses. We do not have enough educators to come and be faculty because, they've been paid much higher in one and other places. So here comes the collaboration. For example, we know in healthcare, we have great, professional, even at the highest degree, terminal degree, that working at the bedside. So the collaboration could be that we can utilize the opportunity to having those come and educate and train future healthcare providers. As we have great collaboration with no one, and we are very pleased. Just to mention, in WSSU, we're bringing 118 nursing students, the highest in the past few years, and also we have had 100% pass rate in NCLEX to the local collaboration that we have. So we incorporate VR technology as well as great collaborations from in the region as well as with the other groups as well. So I'm hoping I answered your question, but generally speaking, you can look into how we can succeed because, as we mentioned many times, we are all on the same boat. So if we want to be successful, then collaboration and competition is going to be there, but how we overcome with collaboration, that's some things that we can succeed and help the community to have the best professional possible to serve their community.
Thank you. This question is open to anyone who would like to answer. So our panel, building bridges and strategic collaborations. The underlying component, at least one of them, would be relationships, right? We are in such a competitive world. How do you cultivate collaboration, whether it be within your departments, within your organizations as a whole, as well as externally?
I would say in healthcare, we can all agree that we're completely overwhelmed, and sometimes we never have the time to do what we want to do. From my experience in this position, and I'll use you as a good example, we're a part of an initiative that's a collaborative that Joyce Rice is our president for, called PATH. And through this experience, we found out that a lot of students are having trouble completing because they need support, right? They have issues with childcare, transportation. So I was able to take that information back to Cone Health, speak with our philanthropy team, and we were able to provide some financial solutions to support those students that I was told, for example, that they couldn't even afford the vaccines, right, just to come and be in a place like Cone Health and do the clinical rotations. So my point of all that isn't to brag on that relationship and how it worked out. It was literally a 5-minute conversation, and if I wasn't willing to kind of set some of that work aside and get out within the community and talk to our partners, we could work together towards that solution. So
I'm an introvert, as you can tell. I will be quite exhausted after this is all over, but it's in the best interest of my employees, it's the best interest in our patients that we're having these conversations. Again, we talked earlier about other sectors and what they're doing. We can't innovate if we don't receive some ideas, so I'm thinking about doing things.
One of the things I'd like to share is that at Novant Health, the campus recruitment team that we have that travels and engages with our academic partners was birthed from a need to understand that we needed to have consistent engagement with our partners, but as well as our students, right, to hear from them directly. Well, also shares that we have quarterly meetings with our academic partners as well, so that they have an opportunity to engage with our team. I lead a team who manages the onboarding of every student that comes to Novant Health for a clinical or non-clinical rotation. So we use that as an opportunity to receive feedback. And then we have an additional layer where the leader from the campus recruitment team also engages with our academic partners. And then lastly, opportunities like the opportunity today to engage with you, to hear from you, to collaborate, to share our concerns, and then to go back to the drawing table. We have many initiatives and partnerships that are supported by philanthropic efforts. And so we continue to pivot, which is, I wasn't asked for a word of the day, but it's definitely my word of the day. We continue to pivot and create opportunities just to have these long-standing conversations so that we can meet the needs of our stakeholders.
So when it comes to collaboration, I'm all about collaboration, work collaboratively. I think pivot, as needed. I think those are, essential. So when I'm looking from an educational perspective, we know healthcare is a team. So it's not just one profession who can provide all services to the complex patient needs that we have. So which means every healthcare professional needs to know not just others that they are PT, OT, RT, and others. Rather, they know they need to have a mindset that there are other experts and professionals who can do much better job if they collaborate to the patient's population as well. So interprofessional, interdisciplinary collaboration is some things that I'm personally passionate and also really helping students to better understand that they do not need to carry all the load just by themselves. There are others available, and their goal and their job is also to help patients and provide caring. Patients in the past, as nurses, we always say, we are caring for patients. Yes, we do, but every other healthcare providers, if they are passionate, they need to care for healthcare or for patients as well. So collaborations comes to the fact that we have a mindset that it is everyone's responsibility to make sure that we provide the best and highest quality of care and services to patient population, community, and the society as a whole. The other piece that I want to bring it up, when you look at the student success, for example, at WSSU, almost 70% of our students are coming from, community that their parents would not be able to support them financially throughout their education. Doesn't matter, 70% almost. So which means they have to work in a full-time job, full-time students, some of them full-time parents and dad or mom. So in that case, collaboration would be essential to help them with the community, if they have kids, so to support them, and financially as well. So we are grateful to no one and many others to provide some scholarship for students, because if students need to work 24/7 or as a full-time job, so it would be hard that they can concentrate on their education as well. And that cost, 4 years graduation in North Carolina is only 50%. So which means there are more work. And remember, every day that the students cannot graduate at time, it added to their loan, added to their cost and all. So the sooner that we can graduate the students, we help the community because they will become a taxpayer. They will become social mobility to the society. Sometimes if we look at the root causes, we can come with better solution because resources are there. Sometimes we are not aware of the resources. So those collaboration and networking help to bring the right people at the right table to make sure that students who come in, we have had just yesterday from our new cohort, 3 students came. They really need the financial support because because for their renting or other issues. You have some financial support, but for sure that the society will have more. So again, knowing each other's, their jobs and their roles would help us at the education and university to help these students go through their education as successfully and as efficiently as possible.
I was just going to add real quickly, one, I love hearing this idea of really understanding your core employee base, user base, what the barriers are that can happen for folks that come into the workplace, and I think that is so critical, understanding what it means for the folks who live next door to us and work next door to us. What does it mean for them to be in the workforce every day, and what are the things they need to be really successful? Two other things I want to call out about collaboration. One, I just want to note that our region in particular has a really strong history of innovation and collaboration and advancement. So I would, thinking of healthcare and comparative industries, if you take a look right now at advanced manufacturing, you think about the history of our region and where our manufacturing started and the things we were producing, and then you look today at the folks who are manufacturing in our area and the skills that are needed to do that. We're talking about the first new supersonic jet is going to come out of this area. We're talking about Toyota is producing, electric vehicles for batteries around the world. Those are all new skills that have to be developed. And we talked about AI. It's going to change tomorrow. There's going to be a new skill base that you need. So I want to circle around the idea that we are really good at developing those basic transferable skills and keeping our eye on what those skills are and what are those skills that can work across all industries, because whether we like it or not, all industries are going to compete. We're all in a place where, you're going to look at all these. And so what are those transferable skills? How do we build those most strongly in our student skill set? And then give the opportunity for collaboration provides the chance for those students. I always say you can't be what you can't see. If you have never been in the ER, you have no idea what it means to work in an ER. And so how do you create the collaboration for them to have that experience? So I have great hope around this. I think that, again, bragging on the students and the folks who are coming out of our school systems here, they're amazing. And the idea that mindset of innovation really rests in this area.
Wonderful. So on our panel, of course, we have educators, we have employers. We kind of touched on economic development, but what about community agencies? The strong need for partnership there, and have you, within your careers, experienced that collaboration or desired to, but found some barriers there? Anyone can speak on that?
I can start. So again, bringing some facts just to be factual here as well. We know when you look at healthcare outcomes, only 20% of health outcomes are related to hospital care. 80% are related to the social determinant of health. That's the place that community services are crucial. And the other piece, remember, we in the U.S. having the highest expenditure, health expenditure around the globe. Even if you look at OECD countries, peer countries like U.S., we are paying 2 to 3 times more for healthcare than any other countries around the globe. Canada, is coming second, but U.S. is the highest. $4 trillion it was just for 2022 in terms of the total health. If we are spending so much, then we look at the quality, where we are at when it comes to ranking. Unfortunately, we are 11 out of 11 countries when it comes to quality of care, access, and number of doctors. So that shows that we are spending a lot on hospital care, acute care, when it comes to community care, social services, home care, and a number of others. Maybe we are lagging quite significantly. So what we can do, because we know, maybe when I was, in 1990s, if we go back, patients would stay in hospital if they had a surgery for 2 weeks. We would do every kind of support and services as a nurse until they are ready to go ahead and rock the road. But these days, patients will be discharged even after open heart surgery, after a day or 2 days. Who's going to take care of those? Unfortunately, we don't have a strong system to do this transition and make sure that that person, the patient after surgery, would not coming back in the ICU because of embolism or some other, or infection or septic and others. So again, those community support and services would help with the healthcare system in general, as well as the community, that we can best utilize the resources. So I'm going to stop and
Thank you. As we bring our panel to a close, we started personally, so let's conclude personally. What principles do you take from your personal life that you apply to your professional life when it comes to, again, building those relationships?
Well, I'll share that I am a woman of faith as well, and I grew up in a very strict home. And, what resonates with me is, you do unto others as you would have others do unto you. So I feel like that my life is a life of service. So in the work that I do, my goal is to impact the lives of every person that I touch. Out of the 218 students who have come through the program, or a collaboration within our organization, maybe assisting another team member with support with looking at things through a different lens based on the toolkit, that I have and that I brought with my years of experience. So I would say that is key for me, because often one of the most critical things in healthcare is that we are, we're doing a wonderful job at Winston-Salem State University of developing future talent and pipeline, but each of those students who come out of that school come with a different toolkit, which is a different experience. So each day I move forward so that I can share with others my experience, again, so that they will have an opportunity to look at things through a different lens as they move their work.
Thank you.
hard questions, for sure. So I'm a person of service. So wherever I go, I want to make sure that I provide the best services to the client, to the population that I serve. And for that reason, it's great, for example, when it comes to education, to make sure that students have the resources from, financial to, education, to tutoring and others to ensure that they can be successful in any career, any positions that they're moving forward. So it would be for myself to facilitate, their process in order to effectively and efficiently. Again, efficiency is important. I always in terms of the research, I'm quantitative, qualitative, mixed method, so I do not compromise one for other. So effectiveness is essential, but at the same time, efficiency is also important. Agile, is some things that always I'm eager. Because in the past, sometimes we would spend years of planning, and as soon as plan done, everything has changed. No need to go back to planning. So with the AI and the technology, sometimes being agile and nimble, planning is essential. We need data, but at the same time, there are lots of data out there. Remember, big data is there. So every one of us, we have verbal devices that can collect lots of health information that could be utilized. So again, how to plan and how to look to improve, I think that's something that we can, personally, I can work every day on to make sure that we serve our population the best way possible in the short period of time that we have.
Well, for my personal life, I come from a long line of naggers, so I would say when describing workforce development, probably in any sector is that persistence and that willingness to continue moving forward, even when your ideas or the proof of concept that you share with your leadership, it's really just not working with them. So my job is to connect the pieces. For the students that can't afford their own clinical rotations, it's my job to say, hey, there's opportunities that we can assist you with. So again, as an introvert, it's my responsibility and also as a helper to be that voice between the community partners, the schools, and our own employees' needs. So I came to Cone Health and started our Career Development Center with my colleague Travis Den. And it's been an honor for 3.5 years helping folks to develop. And now I can do that in a much bigger way. Rather than just individual employees, now I can take that same level of service to the community and help build pipelines that are desperately needed. So.
Thank you.
They're all really good answers, so I have to think on this for a minute. No, I actually know my answer right away. I am a personal believer that access to education and a fair-paying job changes lives. And when you have equitable access to those things, to both the education and the fair-paying job, it not only changes that student's lives, you can change the lives of their family, And honestly, it betters our community. So this is work in that space. I think we all sit there in providing access. And the idea of a fair paying job in an industry that they love is really important, and I think it's important work. So thank you for having me.
Thank you. Do we have time for one question? I'm looking at my timekeeper. Do I have time for one question? One question. All right. Is there a question in the room? Is there a question in the room? No question. Oh, there is a question.
I'm gonna just, it might be longer than we need, but as I think of our students and many of the 50,000, as I think of the students and the many 50,000 that are in the city, many of them, at least I can speak for our campus, the majority are non-white, many are first generation. They're gritty, they're devoted, they're needing to find their way. We use the term you use quite a bit, which is meet students there. How do we meet students where they are? They may not have come from an educational or a city or a school system where they have the same advantages as others. And so as I think about that, what can we do better? How can we make it easier to connect with you, recruit, share your information, especially as we think about local companies that are here and what you're doing on a daily basis, which is talent acquisition and trying to provide resources.
I know I would like to respond. I'm not on the panel, but I want to say perhaps you don't even realize your team is doing a phenomenal job already. I know myself, I've worked with Bianca in the career advisors who've done my interviews, LinkedIn, resume basics, things of that nature, focus groups. But also there was a young lady that was talking about the Bryan School of Business. I just went and had coffee with Stephanie Weber. And we were talking about how to partner there and expand the relationship there. Working with Health and Human Sciences and going in and doing classroom presentations. So it's like your team is already doing great jobs. I know I can speak personally. I'm sure it could be expanded upon, but you really are doing an amazing job. And I think primarily it is being willing to open your doors for that collaboration to let us in, because sometimes you can find there are some institutions where they don't want people in, or it could be because of biases. So it could be because I work for Novant Health, but faculty works for Atrium or Cone. You don't want us to come onto the campus. So I think being open and allowing the students to have that selection to choose who they would like to go to based on their preferences, I think is key.
I could do a shout out for your grant that UNCG recently received in several millions of dollars to help those humanities students that can't find experiential learning experiences. I can say we were able to talk a leader within our philanthropy team to take an art history student for our spring internship that just wrapped up, and she blew everybody's socks off. The end of the conversation was, what can we do to keep Liz here? So any of those types of opportunities, the worst we can say is not right now, or I'm not sure, let me dig in deeper to that. But most of the solutions that we've been able to come up with over the last year and a half have started with, this is what we need, get back to those UCS solutions. So I'm not the TA for that, but that's my...
You're great. You're getting it.
So would that be answer to your question? But we know, for example, on the news is that 2026 is going to be a class for enrollment and others. We need to remember that, as was mentioned, for example, if we look at the data again, those families who have, graduate degree, professional degree, their income is 2 to 3 times more than those who are at diploma and even bachelor level. That's the way that we need to share, specifically with the underserved populations. We need to make sure that, because again, there is roaming out there that higher education degree is not needed anymore. Right? Reality is needed, specifically for the population that we serve, because we need more representations. So we need to make sure that the mindset and also the messaging is clear that yes, you need to go to college, you need to get your degree, not just at a bachelor, a much higher level, in order to have a better quality of life and incomes and fair and equitable income as well. So again, that's something that is important to share.
Thank you for the question. Thank you for being so attentive. And can we give a warm round of applause for our panelists? Amazing. just very happy with the information. That was a very spirited panel discussion. Lots of takeaways. Thank you, Natasha, for moderating, and thank you, panelists, for being here. We are just so excited that you're in the room, but right now we have a little under 10-minute break. Take a minute and a half away from you all. But if we can go ahead and do a 10-minute break, continue to network. I don't know if you have business cards or what you have to exchange information, but please continue to network during this time and help yourself to the restrooms, which are down the north corridor on the left. And we will start with our next speaker, who is Chi Wong, who will be discussing North Carolina's healthcare industry labor market now, then, and next. So we are on break for 10 minutes, and then we will resume.
are so excited that we have a short announcement.
And we're going to reconvene as we are ready to round out the latter part of this amazing event. So if we can have everybody, no one's going to get in trouble, I promise. So we are really excited to move forward with our agenda. Hopefully everyone's had an opportunity to take a good break and to get refreshments and continue to network and exchange information. We are super excited about our next speaker. We are looking to welcome Shifong, who is going to discuss North Carolina's healthcare industry labor market, discussing now, then, and next. So we're very excited to welcome him. If you can help me welcome Shifong to the podium.
Hi, everybody. Thanks so much for the warm welcome and being here. This is the first time. This is a really weird moment for me because I graduated from UNCG like 10 years ago at this point with the master's degree. So it's like a full circle thing for me to graduate and then come back and give a talk about something related to my job. So it's just life takes you in strange places, I think. Strange places. Okay, so I know we're running a little bit behind, and thankfully I think I have roughly about 25 minutes of material, and there's with a little bit of time for questions at the end. So without further ado, I'll go ahead and get started. So just sort of a brief layout of this presentation. First, I'm just going to start with giving out a lay of the land and where the economy is at right now, the labor market is at right now. And then we'll get a little bit more specific in terms of an overview of the healthcare sector. And finally, we can sort of end on a more forward-thinking note and talk about some challenges and what we can do about them. Okay, so let's set the stage a little bit. I don't know how many people, I mean, it's my job to follow the economy, but I don't know if everybody else is following the numbers. And sort of I've got 3 charts for you. We don't have to go through tons of slides, which is great, but we'll instead just go through 3 charts. So one, job growth continues. Maybe, I don't even have to ask anybody just who experienced some great economic catastrophic change in the last 5 years? Just me? Anybody? Oh, okay, well, great. Well, COVID happened, and it looks like, according to our latest QC quarterly census of employment and wages numbers, we have actually not just recovered in terms of the total number of jobs, but actually gone past the point at which we were at before. So that's pretty good news, I think. When we're talking about the labor market, there's job seekers, job applicants, right? How many postings there are versus how many people there are looking for jobs. And according to our data, where the orange line is the job seekers and the black line is job openings, we actually have slightly more job seekers than job openings. It's a very slight difference, and there's some historical context that I have to discuss later, but this is an interesting sign given, again, what we experienced during COVID, where the number of and even during the recovery, where the number of job openings exceeded the job seekers. So, last but not least, the story that is, I'm sure everybody is familiar with, as the news keeps harping on, inflation is drastically eating into wage growth. So, the black line is nominal wages, and the red line is real wages. And this green circle here, I'll go back and press forward again, just to highlight that is a huge gap in the reported private average weekly wage. So. Job numbers are looking good, job seekers and job openings are also looking good, but we have this situation where people don't really feel like the economy is necessarily improving for them in personal context because everything's getting more expensive. So, okay, that was my very brief lay of the land. So now maybe let's get into some more specific information. Okay, again, so I'd like to starting from a very broad view. If we break down the top 10 sectors by employment according to our latest number, we see that healthcare and social assistance bears the biggest share of the jobs in the current number of jobs in the economy. Again, healthcare and social assistance are roped into one, so for the purposes of the presentation, I just highlighted the healthcare part, and we have, again, roughly 1 in 10 jobs are associated with healthcare. That's a pretty hefty amount, I would say so myself. And when we go down to the county level, this is at the statewide level, and if we go down to the county level, it's actually the largest sector in a little less than a third of our counties. And if you think about the top 2 or 3, it's actually an additional 51 more. So in other words, healthcare is just a very large industry sector across not just not only considering state as aggregate, but across individual counties. Okay, so healthcare is a very broad industry sector, and thankfully we have ways to break it down. We use a system called the North American Industrial Classification System. I won't get into the weeds, but you can break it down a little bit. And when you look at the splits, it's about 43% ambulatory healthcare services, 41% hospitals, and 16% nursing and residential care facilities. I don't think this is too terribly surprising, but it's good to have the breakdown anyways. Okay, so it's fun to talk about industry numbers, but I think most people engage with our data and data about the economy in terms of the workforce, right? Like people. What are the people that work in the healthcare industry? What are the demographics? Race, and so on and so forth. So again, not too surprisingly, the workforce is largely female. There's societal and cultural biases towards females in the workforce. There's initiatives all the time to raise the proportion of males in the healthcare workforce. But anyway, around 4/5, 4 out of every 5 healthcare workers is female. And when we were looking at sort of the racial distribution, when it comes to ambulatory healthcare services and hospitals, it's a largely white workforce, 72% white, 21% black, and this sort of matches the overall, total all industry employment distribution in terms of the race. Okay, but interestingly, and I want you to keep this in mind when I talk about sort of some of the wage details. We actually have a larger black workforce in care facilities. So we have, it's still there's still a larger share of white people, but 46% relative to 21% in that previous sector discussed before. It's a pretty big difference. So again, a larger black workforce in the nursing and residential care facilities. And this surprised me a little bit, but maybe it's because I'm not super intimately familiar with the healthcare sector, but we have actually a little older, the workforce is a little bit older in care facilities. So there's about 30% over the 55 or older versus 24 to 25% in the ambulatory and hospitals part of the healthcare sector, as well as North Carolina overall. Again, it's a 4% difference, so it's not that big when you consider, or it's not big in percentage terms when you consider the amount of people that work in healthcare. That could be, tens to hundreds of thousands of people. Okay, so the economy is sort of trending upwards, so wages kind of have a big inflation gap, and we've sort of seen this sort of, I've sort of given you a brief overview of the demographics of the healthcare sector. Again, ambulatory and healthcare are mostly white, slightly younger, and nursing and residential care facilities, they have a higher share of black people relative to the ambulatory, and they're also a little older. So let's maybe talk about some challenges. So first up is talk about wages, wages and employment growth. So when you look at this sort of, again, looking at this by graph, this graph depicts sort of where the employment has been relative to the pre-pandemic situation. And, okay, great, this waveform is that small, but that's okay. So we see, again, here's where the pandemic happens, the employment dips down, it recovers, and, we hit this sort of inflection point around 2021 where recovery has sort of largely taken its course, and all the way up until the most recent data, we see that the total all industries employment rate has sort of exceeded the healthcare employment recovery. And actually, this is a good opportunity for audience participation. Can I get a show of hands? Does this match everybody's intuition at all? I actually don't know. Do people feel like healthcare in general is having more trouble recovering, on the grid? Does anybody have any impression about that? A show of hands is fine. Okay. Okay, so that's great. I'm glad that the data. It's always important for me to make sure that the data reflects people's experiences, because that's useful for me to do further research if it doesn't. Okay, and again. That was very broad, now we're narrowing in a little bit, and we're looking at unequal, and so now the overall message of this graph, when we look at sort of individual industry recovery relative to before the pandemic, is actually that employment is particularly slow to recover for nursing and residential care facilities. In fact, they're at like 10% lower relative to where they were before the pandemic, whereas ambulatory healthcare services and hospitals have actually grown very slightly. And again, you can sort of see how drastic the difference is as a matter of scale when you consider that the healthcare industry overall has been making this sort of general kind of growth. So this has some further implications that we're going to talk about in a little bit. Okay, and maybe getting to the most critical part, to me at least, we're talking about unequal wages here. So I think it's no surprise to everybody that ambulatory healthcare services and hospitals workers tend to make more than people in nursing and residential care. Whether or not we feel good about that is another story entirely. I don't feel good about that. It's just me. But when you're looking at even when compared to the statewide average, right? These two subsectors make slightly more than the statewide average across all industries. And when you look at the nursing and residential care, this is just got that $24,000. So that's a pretty big difference in terms of the nominal wage. And of course, the picture is slightly more rosy, only slightly, when you consider that nursing and residential care facilities' wages are making gains against inflation, especially when considered against, say, ambulatory health care at 5%-ish, and hospitals at 12%-ish, and even compared to the total all industries number. So, story is not great in terms of the wages for nursing and residential care, but at least they're making gains against inflation. And I think it's a fair statement to say that a neater summary of this is that yes, they're making gains against inflation, but the level still has a ways to catch up to the statewide average as well as other healthcare subsectors. Okay, and so some more. We can also break this down by occupation. As I said before, I think most people engage with our data in terms of the occupational side, not just the industry side. And it's about like a 37% break. Whilst 37% of the occupations in the sector belongs to sort of all other occupation groups, the remainder, like 40-ish or 60-ish%, are comprised of healthcare-related jobs. And we divide these in our data according to healthcare practitioners and technical occupations, as well as healthcare support occupations. So, just starting with the practitioners and technical occupations, about 60% of these jobs are in hospitals, with 39% in ambulatory and 50% in care facilities. Most of these jobs require a minimum of a bachelor's degree, so the barrier towards education is quite high, or can be quite high. And as reflected in the industry trends, we also see mostly good to great wages in terms of their median annual wage. This is, in fact, a stark contrast to the other set of healthcare occupations, which is our healthcare support occupations. So in this case, nearly half of these jobs are in the care facilities. Actually, all of them require less than a bachelor's degree. And actually, most of them have a median annual wage, of $35,070, which is, I would go back quite a ways, but it's like below that sort of 60,000-ish mark that we saw before for the total all industries. So now, and even when you compare to other occupation groups, so when we're comparing apples to apples, we see that this group ranks in the lower third of the median wages out of the, I think, like 20, 21-ish occupation groups. So clearly there's sort of a big policy challenge around bumping up the wages in healthcare support occupations generally, as well as, and this also means, again, like bumping up the wages for jobs that require less education. Okay, so again, just to summarize, we see these low wages among healthcare support occupations and in nursing and residential care facilities, and things aren't totally rosy for hospitals and ambulatory care jobs because those jobs have wages that are paying well, but still have some work to do in terms of keeping up with inflation. Okay, talking next about another set of challenges which has more to do with the hiring situation. So this graph sort of depicts the number of job seekers per job opening in North Carolina. This is a way sort of to track how easy or difficult it is for people to get jobs. The more job seekers per job opening, the more competition there is. The less job seekers per job opening, less competition there is for a job seeker. And when you look at this graph, remember before how I said the number of, job opening or job seekers slightly exceeds the number of job openings, and that's maybe a good sign for businesses. Well, the problem is that we're actually still kind of at a historic low for this sort of job seekers for job opening ratio. So in other words, employers are still going to be struggling to find workers. So, when we're looking at this generally, this job seekers for job opening ratio is at a historic low, and we see that reflected in the healthcare practitioners and tech occupations with, like half a job seeker for job opening, as well as the healthcare support occupations, which is like at 0.2 job seekers per job opening. And so why? This is a ratio. It's either the job seek, the numbers are in relation to each other, and the answer is that there are fewer job seekers and greater job demand relative to, say, like the start of the pandemic. So when we look at, again, the number of job openings available, there's a little less than 8,000 available for healthcare practitioners and technical occupations, but there are actually roughly 5,000 fewer job seekers relative to the start of the pandemic. Similarly, for the other swath of occupations, we see about 5,000 more job postings or job openings for healthcare support jobs, but we see 2,000 fewer job seekers. So this sort of lopsided ratio is why, we always talk about this sort of policy challenge in the future in terms of filling the healthcare occupations gap. But we see that even now we're really sort of feeling these effects. And just a bit of audience participation again. Show of hands, who's heard some hiring struggles in the healthcare industry? Yeah, that's like basically the whole group. So, and maybe as another sort of benchmark, while North Carolina in general is sort of experiencing this gap in job openings and job seekers, but why did the -5? It's supposed to show a 33% increase in job openings and a 5% decrease in job seekers. So, it's not just about the labor market. It's not just about the sort of like general hiring conditions. We can maybe get a little more specific. We have this employer needs survey that we administer once every 2 years, I want to say. The 2023 iteration, the data will come out, I think, sometime this fall. And so when we look at this employer needs survey, we are able to sort of divide it by sectors, and 61 out of the people that we surveyed, or firms that we surveyed, 61% of them reported difficulty hiring. And when you look at this tornado chart of the reasons for difficulty when it comes to hiring among healthcare firms, we see, as corroborated by our job openings versus job seekers data, there's a low number of applicants is a huge reason among both entry-level and experienced positions. Next of which is a work experience gap. I ordered these by sort of their average between the two. So this low number of applicants, so work experience and employability skills are the top three, where employability skills are just sort of more, this is surprising, like employability skills are more kind of like generalized things like work ethic, or, your ability to just show up at the job on time, or have good communication skills. And I think the sort of ranking of this is really stark when you compare it to technical skills, which are some of the lowest sort of problems for employers who are looking to hire for both entry-level and experienced positions. Again, this is like 24% and like 34% versus the 57% and 38%. So it seems like employers, when we're asking them questions about, okay, well, like, why are you having trouble hiring people? It seems that just being a good employee and finding good employees in general, not necessarily accomplished employees or I guess like healthcare competent employees isn't the issue. It's finding workers that they feel like they can trust and invest in. And when we're talking about sort of barriers to employment, these are the grayed out fields are things that prospective employees or like applicants come back to them and report in terms of, why did you turn down the job? And it turns out, I think to nobody's surprise, based on the sort of age range of most healthcare workers, childcare is a huge issue. The cost of childcare, and next up is like transportation and commuting time. So this is, again, this overall picture of the labor market suggests that there's lots of job openings available in healthcare, fewer people applying, and even among the people that are applying, employers are struggling to find people that they feel have sufficient work experience or just good generalized working skills. And last but not least, this is this is important still, but I thought this was very surprising to me to see. This is sort of a graph of the industries by rate of injury or illness per 10,000. The most recent data was produced in 2022. This comes from the BLS, and this is a dangerous business. I mean, nursing residential care facilities show 300 injuries per 10,000 workers. It's I don't know. It really puts into perspective to me, especially relative to the other industries and relative to the all industry average, just sort of how relatively dangerous the field is, both in nursing and residential care facilities as well as hospitals. And I think when I was reading sort of the report done by the DHHS and the IOM when they did sort of a general state of healthcare and path forward, this was sort of reflected by a lot of their first-party feedback, was that the field is dangerous and we need to do a better job of addressing these sort of potential for a workplace hazard. And again, I love audience participation. Has anybody heard of anything like this? How many people have sort of heard a story from somebody that they encountered something kind of scary or harrowing at their healthcare job? Okay, so through that, so this is not totally new to everyone. So again, there's this challenge of finding bodies now in terms of the labor market. We're facing this labor shortage among the economy, and there's more competitions for workers ever than before, especially those healthcare support jobs, which are a lot more dangerous according to the data, and also pay less and require less education. So we need to find some way to attract workers to the industry. Okay, and last but not least, I'm going to talk about the growth trajectory of the occupations within these industries. And hey, this is a pretty rosy picture. I've sort of done a growth rate ranking, and healthcare support industry or occupations are projected to grow quite quickly relative to the other ones, and healthcare practitioners and technical are still projected to grow relatively quickly in this sort of 9-year time span that we have this projection for. And looking beyond occupation groups and looking more at individual occupations, this is sort of a ranking of projected healthcare occupations sorted by their average annual job openings. And we see, at the top of the list, we surprise some of these, this healthcare support job in the form of home health and personal care aides. We see some registered nurses, nursing assistants. These sort of jobs, I think everybody expects to be near the top. And I want to emphasize that these jobs are expected job openings. So these are not necessarily promised people, but rather the positions that we expect people to need to fill during this 9-year period. And the reason why I make this emphasis is because it sort of just highlights that this is what we're hoping to fill in some capacity, and this isn't necessarily our projection of how many people will and can fill these jobs. And so when you see, I just sort of tap it over to show that a large swath of these healthcare occupations are actually the ones that we project the most total average annual openings for happen to be the ones that are in healthcare support. And if you recall what I talked about before, these are also the jobs that kind of pay a little less. So there's a situation here where there's lots of jobs that pay a little less that we expect to have a lot of openings for, and there's sort of a workforce challenge there too. And just as a summary of this section of my presentation, again, we see that these healthcare occupations we expect there to be strong growth, and we expect there to be very large numbers of projected openings. And I didn't talk about this in detail, but sort of as you might expect, a lot of these are due to turnover. A lot of these occupations are filled up by people who are older and maybe want to retire or maybe want to do something less intensive, especially because they're not being paid as much. So so we have these sort of trifecta of challenges of the wages and filling filling jobs with bodies as well as meeting future growth. Okay, so this sort of, as we wind down this presentation, I want to sort of bring it back to the big picture. So again, not all healthcare jobs are back, right? We've experienced this total the economy has experienced a recovery, especially relative to the pandemic, but and so has the healthcare sector, but the return has been experienced unequally, and particularly we see this large gap between the nursing and residential care subsector versus the hospital and ambulatory services. And hey, we see that even this point I made earlier is, I want to hammer it home again, it's like, we see those low-wage jobs in the nursing residential care facilities industry, and yes, they're increasing pay, and yes, they're accounting for inflation, and that's great, but hey, those two other subsectors which bear more of the employment are seeing slower wage gains relative to inflation. And finally, we see all these, we want to increase the interest in the jobs and education for these fields, especially because we expect to keep growing and we expect to face continuing hiring challenges, not least of which would be healthcare and support, healthcare support occupations. So, being a little more forward-thinking, and I think this is sort of my intended kind of like group discussion, open invitation to raise hands and discuss slide. Like, we really want to ensure that our current and future workforce is equipped and prepared to work in healthcare. We want them to have as I alluded to earlier, there's lots of wealthy occupations are in that sort of technical healthcare field that require a little more education, right? So we want to make sure they have the right credentials, the right education, and the right skills, and not just technical skills, but also the employability skills. What does it mean to be a good worker? We need to instill that in the workforce of the future. But people also need to live and need to be able to pay for their standard of living, and so we want to, again, address the childcare concerns that people seem to be going back with. We need to be addressing the transportation concerns that people might have, as well as, of course, the ever-looming concern about the wage. And last but not least, the field's dangerous. The field can be dangerous. The field can be very exhausting, and advancement can sometimes be difficult. So we want to figure out some career paths for workers at every level, including those among the lower income rungs. We want to make sure they have good benefits, a great environment, and have rewarding work. And I think this point, again, I did some extra reading outside of this, and all 3 points are corroborated by that sort of Department of Health and Human Services landscape study, as well as the IOM study. But I think they really spend a lot of time talking about building up career paths and building up ways for people to feel safe and rewarded in their job, especially as the demand for healthcare occupations and healthcare workers increase, what with the aging population as well. So, this is the end of my presentation. I haven't been keeping track of time, but I'm welcome and open to any and all questions and discussions about this. Okay, 2 questions, sorry. Oh, sorry. And anybody who would like to ask a question or comment in any capacity, please feel free to raise your hand. Okay. With no questions, I would like to thank everybody for your time. I can be reached at my email. It's up here. Since I have a tiny bit of time with Black questions, I'd like to do some plugs. So we have this blog feed called the Lead Feed. It's on our ncommerce.com website. Where you post. Oh, there is a question in the back. Hi. May I have you, please?
With the in-home care,
Sure.
how do we try to make how do I want to put this? How can we attract people and keep them, because with home care, that door swings. As fast as you open the front door, the back door is opening for them to leap out. How do we find a way to, attract them and retain them in that realm?
Just to make sure everybody hears and to make sure I heard correctly, so you're wondering about how do we slow or stop the revolving door that happens in healthcare, especially for people who are newer to the workforce, is that right?
Or in-home, in-home.
Oh, in the in-home care specifically.
Yeah.
No, that's a really good question. I think, again, I have a very limited perspective on this, but I think from what I've read, it seems that one of the big challenges around in-home care is just the data. We just don't have a very good sense of this is a little bit outside the scope of what you're asking about, I recognize, so bear with me. One of the challenges is that we just need to get better measurements around what was happening in that sector. have some ideas around what's going on, but not the precise ideas. So one sort of like the groundwork step is just to figure out what the problem is. But in addition to that, I would say that I think part of it too is showing one suggestion that I've read from those two sort of recommendation policy booklets is creating a network and a system of learning for people who are in that field. I think their workers in those fields can report feeling like they don't really know a way forward or how to advance in their career, and also there's a lot of expectations placed upon them in that in-home care field, but there's no sense of how to manage those expectations or how to effectively carry out their job, especially when working with folks who have more needs or who are more challenging, like older or very sick people. So yeah, I would say it's building a support network. It's getting a better grasp of the situation by getting better data, so that way we can come up with better policy solutions. I think finding some way to this is the ever-present concern. I think like finding ways to pay them more would be good. So yeah, some combination of increased pay, on the workers' end, increased pay as well as creating a better professional network for them, the infrastructure for a professional network, and on our end, coming up with ways to track what's happening and to be able to better target whatever's happening in that field. I have one more or no? Okay, that's fine. Well, we don't have any time for any more questions, so thank you so much again for your time today. I really appreciate it. This was, again, a crazy full circle moment for me, so I really appreciate you guys taking time to the audience. Thank you so much.
I just want to thank for the information. The last question, definitely hold on to that question, because we are going to have continued discussions about how we can really mastermind roadmaps to some baseline solutions and really developing some strategies around modeling and things of that sort. So it is a never-ending discussion and conversation, so thank you for your question. And we're going to have an opportunity for you to have additional questions post the event, as well as some working groups ahead that I believe will be beneficial for us to process and to be good stewards over the information that we've received on today. So without any more delay, I'm so excited about this next panel. Very, very excited. We have, and you don't want to miss this panel discussion, by the way, so if you are planning on leaving, I would advise you not to. We are so excited about having this next panel discussion moderated by none other than the Warren Crow. He is such a value to our community and all that he has contributed. Warren, along with others, have really shown the ropes in healthcare and have supported so many initiatives that have taken place and have he's added so much subject matter expertise to our community. So this is going to be a great panel, and it's an apprenticeship models and workforce success. We talk about how we can look at retention and retaining employees. Work-based learning opportunities are just conversations that we need to have more often, because they're not the easiest dynamics to understand. So we're very grateful to have this panel on today. And if you all would just welcome them, I'd like to quickly introduce the panel, though. Would be remiss if I didn't do so. Wanda Ramos McPherson, who is the Triad Regions Apprenticeship North Carolina consultant with North Carolina Community College's apprenticeship. We're excited to have her. We're also very excited to have Dr. Holly Myers, who is the Dean of Health Sciences at Davidson-Davie Community College, as well as Michael Jones, who is Talent Acquisition Campus Recruiter with Avant Health. And Christy Caitlin could not be here, as she is the Director of Human Resources at Penny Byrne. But please welcome them with a great round of applause.
With that introduction, I better be good. Thank you, Joyce. So, good afternoon. We're going to be bringing this together, but I want you to think about a couple of things. We didn't call this a conference for a reason. We call it a summit. Big difference. Dialogue matters. Right? The other piece is every topic we've touched impacts education, hiring, and retention. So whether you want to look at the DEI, of which there is a fantastic career tool that AI uses that simulates discussions of people of culture and diversity for rural North Carolinians who are looking for a role model to decide, do I go into healthcare or not? The impact of that at the high school level could be huge because there are no examples that exist for high school students right now. TikTok doesn't quite make it for whatever reason. It doesn't pull you to healthcare. So I do think that there's great opportunity as we bridge the DEI discussion, the AI discussion, the data collection that's going on with the talent pipeline, which is going to be huge, because that gives us more than an anecdotal response. As we are bringing all of that together to do our panel discussion this afternoon, which really does knit the quilt back together, we're talking about apprenticeships, opportunity, retention. We're excited to have each of you all here. So with that as the intro, I would like for you all to share who you are, what brought you here. I am a firm believer that your vision is your vocation. It doesn't matter what your job title is. So if your vision is to help others be successful, others to get experience, others to work for a great employer, that's what your vocation is about. One, let's start with you. Tell us about you. 30 seconds or less. Go. I'm just kidding.
Testing.
Good afternoon, everyone. Wanda Reynolds McPherson here, apprenticeship consultant for the Piedmont Tri-Region, covering 11 counties. What brought me here today? Really, the word that I have in mind today is partnerships. And, we've been talking about that all morning and how we can come together in our community supporting the workforce needs of our employers. And so that's what brings me here today, is to share the apprenticeship programs, how we do it, who we are, and that's what I'm here.
Thank you. Dr. Myers.
Hi, everyone. Holly Myers, Dean of Health Sciences at Davidson-Davie Community College. Why I'm here, besides Warren, is in order for us to get out of the workforce shortages that we're in, we've got to be different, do different, and think differently. And we've got to come together and be more collaborative. And so that's exactly what I envisioned when I created the first nursing apprenticeship model in North Carolina and expanded that to include all of my health science programs, is that we just need to do this differently. And we can't approach that same problem with the same methods that we've used in the past. And so I always like to shake things up and do things differently because in education we get really stuck in our ways. But our student populations evolved, our jobs and industries that we serve evolved, so we have to evolve just as quickly.
Thank you.
I'm Michael Jones, or Mike Jones. I am a campus recruiter with Novant Health. I work in the Charlotte region. Pretty much like my colleague Natasha, I go around to different colleges, networking with students, providing them with information and, most important, opportunity. And at the same time, promoting projects and programs that we offer everyone.
Great, thank you. So just to share a little bit, these three are trailblazers, like amazingly important trailblazers. The interesting piece is they're all working behind the scenes doing their thing so that we can emulate and have an opportunity to be successful just like the three of you have been. Again, posing a little context to all this, so circa 1910, and for those educators in the room, we say circa because we don't know the exact date, we didn't look it up, but you need to know it on your exam. So, circa 1910, the apprenticeship model in healthcare really began to take off in New York City. The profession was nursing. And the reason that that happened was most of nursing education actually came across the big pond to us. And we began to figure out that in order to provide health care, we had to have a huge public health nurse anchor. That was the biggest city where we started in. And the other piece of that is that we had to have some continuity to the education. So the apprenticeship model was, if you were single, then you could move into the hospital and you could be trained as a nurse. So during the day you learned, and during the evening you sharpened needles, and yes, that really did happen. You also took care of all the chamber pots, washed all the linens, because there were no disposable bandages. So in order to have everything, you had to learn that process. So the apprenticeship model has existed in healthcare for quite a period of time. Then we morphed to where we become incredibly intelligent after World War II. We decided we need continuity in curriculum. We decided that everybody has to be taught to a national exam because we need to make sure that they're professional, competent, and otherwise could take care of anybody, anywhere. Now we're finding, thank you, great opportunity, which is my word for the pandemic. I refuse to use that word anymore. So now post great opportunity, we've got to morph again. So Wanda, I want you to talk to us a little bit about establishing apprenticeship programs, where that concept came from, but how we're trying to plug that into healthcare.
Sure. So apprenticeship programs, really in 1937, the Fitzgerald Act was established. But here in North Carolina, it's been established now for over 80 years, so we're going on 85 years. And generally speaking, and briefly, an apprenticeship program really is a collaborative partnership between the community-based organizations, and which include not only the community college, the workforce boards, the county schools, coming all together to, again, meet the workforce needs of that employer. But the community-based organizations, and we talk about diversity, include those individuals, the veterans, individuals with disabilities. We look at the underrepresented, those community-based organizations, we partner with them to identify some of those individuals to serve the needs of the employer. So we pull that all together with the employer and our community partners to develop the apprenticeship program. And the apprenticeship program consists of 5 key components. And they are the employer commitment, and that's key to the success of the program. We talked about mentors early on, and they are required to assign a mentor to an apprentice. Then we talk about the component number 2, which is on-the-job training. And so an apprentice is an employee. They are getting that training, on-the-job, hands-on training. They're being paid just like an employee would, and they're what we call earn money learn. Then the third component is the related education, again partnering with the community college to provide the curriculum that's required for that specific occupation. And then the fourth are the wages, the progressive wages, which an apprentice again is an employee, so they earn those wages. And then the fifth component is are the stackable credentials. So what that means is that apprentice can and will earn credentials, industry-recognized credentials. They can earn a community college degree, and then ultimately the nationally recognized journey worker credentials. So that really quick in a nutshell is an apprenticeship program, where we are, how we started.
Great, thanks for that quick summary. Mike, talk to us a little bit about the advantages for an employer to take on an apprenticeship program.
The advantages would be that you can fill the board, in your teams and your hospitals. I'm sorry. You can fill a void by taking on an apprentice. For No Line Health, we have a program that's called SNAP. It stands for Student Nurse Apprentice Program. And how this program works is it started out as an internship for nursing students between their junior and senior year. What they would do is participate in the summer, shadow a registered nurse in different units, different specialties, and kind of learn and see what they will be doing once they graduate. This year we expanded the program where not only do we have the program for the students that are certified CNAs, which is what the nurses had to be prior to going to that program. Now we have a non-certified role where students that are in nursing programs, ADN or BSN, would be able to participate. ADN students, not ADN students, excuse me, but SNAP 1 students would take on care associate roles. Won't be able to do things that CNA students do, but serving more support areas, whereas the CNA students would be doing those CNA duties. But the good thing about that is, at some point they would go to an emergence training where they would get to shadow those RNs on those units and specialties and participate in some of those light duty activities and kind of get hands on what their jobs will be like once they earn their nursing degrees. And hopefully, well not hopefully, and we also opened it up to LPN students as well. So now LPN students can participate in SNAP with the idea of them continuing on their education and enrolling in the ADN program to BSN.
Great. So I think one of the things that you hit on is we do think about right now, based upon what Mr. Wong was sharing with us, the huge gap for hiring. But if you project 10 years from now, our concentration is going to be on retention as well. And we know that apprenticeship programs instill a loyalty that does not necessarily exist currently in the healthcare model. We have plenty of examples in the manufacturing for that, the loyalty piece.
If I could, I wanted to just, Dean Myers. Davidson Davie Community College was one of the first community colleges to establish a healthcare apprenticeship program in the state. And their program includes 13 apprenticeable healthcare occupations, which we truly appreciate. And also to share another example, if I could, Surrey Community College, which is another partner that we have, they partnered with Northern Regional Hospital. And one of the advantages of an apprentice registering with the program, as long as they're high school students, so, I'm sorry, let me backtrack a minute. Northern Regional partnered with Surrey Community College and hired 13 high school students, and those high school students benefited from the state community college tuition waiver. So that's definitely an advantage to that program. We have other programs. The young lady in the back talked about the home care. We have apprenticeship programs to help support it. There's some points that we can help hopefully address there. Code Health with GuilfordWorks has an apprenticeship program, and Code Health is the lead partner to that program. Also, Atrium Health and partnership with Davidson Davie. So just wanted to share some of those examples in
Sure.
the
industry.
And I think the examples are building and building and building, but throw the mic over to your colleague. Throw your mic over to your colleague. So, if you haven't met Holly Myers, you need to meet her for many, many, many reasons. Holly, everything in healthcare is super regulated. Agreed? Like you don't sneeze unless you ask the board, is it okay? Right? And please don't stub your toe, because they're going to find something wrong with the way you bandaged it. I love my board. Let me just 40 years reporting to them, I love my board. But Dr. Myers succeeded in building a bridge of understanding between that regulatory agency and why apprenticeships can work. Share a little bit about that journey, but also about your passion.
Sure. No, absolutely. It gets back down to language, right? We just have to learn how to talk the same language, right? From our accrediting agencies, the Board of Nursing, ASIN, NACLS, every acronym you want to throw Bureau out there that regulates healthcare industries. From their standpoint, they accredit our faculty, our programs, our education, right? And so when our apprenticeship consultants throw out the words on-the-job training, that raises their red flag, right? But on-the-job training in a healthcare field is done all the time, right? It's how do you train that nurse aide to do your particular skills, right? How do you train them to use your EPIC system or whatever system you want to use, right? That's on-the-job training. That counts. And so it's very important that the educational institution, and we're a little odd, in that we are the originator of the apprenticeship and not the employer. And we did that for multiple reasons. That's one, I want to make sure that every single one of my students has the opportunity to be an apprentice. And if Atrium Health, for some wild reason, has no nursing jobs open, then I can go to Navon or a Cone or a small pharmacy or a small practice, right, to be able to live in those positions. And so that just allows my students additional opportunities. And some people, let's just be real, they're not meant to be at a large Atrium trauma one level center, right? They're better at a small community hospital. And so it's really just digging in deep and understanding, having those conversations with the accrediting agencies and letting them know. I tell you right now, out of all my apprentices, none of my faculty had any idea who's an apprentice in their program. It did not change my program one bit. So that's kind of a myth that I think I hear a lot of is, oh, didn't change my program one bit. My faculty had absolutely no idea who's an apprentice. Our students are going to have jobs at a community college and even at most universities because they need to work, they need to live. And why not have a job with you? And why not have a job where you support them, I support them? When we look at retention and longevity, we're seeing almost 100% retention. So in other words, the students that apprentice at Novant, even 2 years post-graduation, at Atrium, even 2 years post-graduation are still at Atrium, still at that small community hospital, Lexington Medical Center. The reason I say almost 100% is because one left Davie Medical Center to go work in labor and delivery on the moon, right? But still within Atrium, right? And so I think that we have a lot of these kind of knee-jerk fears of like, oh, it can't be, we can't, da-da-da. All right, so let's quit telling ourselves that, and let's just sit down and in each apprenticeship engagement with employers. My apprenticeship with Atrium looks very different, even at Davie Medical Center than it does at Lexington Medical Center, right? And all the work is out there. I've shared everything. Literally take a document, scratch out Davidson Davie, put in your name, and submit it to Wanda. Because it's nothing that Davidson Davie can even mitigate the workforce shortages in just Davidson County, right? It takes a team approach. And it's not just a 2-year college thing. 4-year universities can do it as well.
So I think it's a great story, and Dr. Myers is totally right. Everything all of her work is published, it's out there, it's a model. It can be used for so many roles in healthcare, and I do think we get very, I want to use the word stuck. I think we do get very stuck talking about nursing, and we're not talking about the CNAs. I think we get very stuck on talking about nursing, and we're not talking about medical assistants. There is such a structure that has to exist in order for healthcare to happen. And the dialogue, Dr. Matacola, I think he asked a really good question. This is why I like apprenticeship models so much. How do you make things happen? You have to be intentional with your time, and you have to decide. You're going to have a discussion. Because each of us have a calendar on our phone. Each of us run from meeting to meeting. None of us stop to say, Dr. Myers, I read your article. Something this is in I'm pretty sure I did. So, but if you don't take intention, we're not going to move the needle. Because we're caught up in the flow. If you're going to change the flow, you got to decide intentionally, stop, have lunch, have a conversation. That's the only way I've learned. So Michael, talk a little bit about things that were shared with you or that you're aware of. What were the challenges for Novant? Because your big step was to go to SNAP 1. That's been recent, correct? Right. So that's a quantum leap from taking a non-licensed person now and them in, which is where we really need to be starting, right? We wait for everybody to get on the registry. How long are you waiting? 4, 6, 7 months, depends on when the state tests next, right? So talk a little bit about what was the challenge, what was the conversation, what was the leap of faith, because we all have to take a leap of faith.
Well, I don't know if it was really a big challenge because it all exists as part of our nurse residency program. We know that there are some students within their education time that are going to advance quicker based on, where they are as a PSC and AD student. So the demand became students talk to each other about what they're doing over the summer, and students started reaching out about wanting to participate in. Do you have to have a certification, a CNA? So our leaders got together and decided to create the Snap One Row to have those students that are not certified yet to start and while they're working toward the certification, get the experience that will ultimately lead to them working as an RN. So the challenge is working around their class schedules, getting the time for them to start the program. Summers are difficult, a lot of them take summer breaks, but we make it year-round now. Before it was just a summer program, and now it's an ongoing year-round program. So the challenges I see by working that program is, and we're very flexible with the White House, we're very flexible with it, but having them to be able to attend the required orientations, and which is not a lot taken away from them, but it's a challenge for them because they can't afford to miss a lecture or a quiz or a test. So that's the challenge, that one big challenge that if we get across that threshold, then I think everything else will flow smoothly for the students. But we have some plans that we're working on to assist them with that, breaking up the orientations instead of having them do it all in one day or 2 days, and you can come back and finish it another day or another week. When your schedule allows. If you don't have a test this Monday, then come back in and do your orientation at that time. So just making it flexible for them kind of works out the challenges of their class schedule.
All right, thanks for sharing that. So I do think, Wanda, you had talked briefly about that this is a model that can be applicable for many, many arenas, and home health folks, this is a great opportunity to begin having that conversation. Having worked in home health for a period of time, the challenges are, believe it or not, more significant for home health. Probably long-term is next, than versus hospital. Because home health requires that you have child care, not on site, you have transportation, none of your clients live on the West Line, and let's just say public transportation in North Carolina is bad. And the other piece of that is most of your clients are needing off-shift care. So the 3 major hurdles exist right there. So the chance working with Wanda and thinking about creative apprenticeships. I know Penny Byrne did some stuff for a long-term person, and Kristen can't be here with us today, but I know that you helped them in looking at that pre-CNA, the pre-apprenticeship program. Do you mind sharing a little bit about that as well? Because I think that's got some home health possibilities.
With Penny Byrne?
Yeah.
Okay. But can I touch on the home care
Yes.
for a minute? I did want to share an example, ComforCare. And Goodwill is here with Tempe. She was a great partner that's the key word for me today in partnerships. And working with ComforCare, they are a home care provider. But with regard to some of the funding, GuilfordWorks funding was instrumental in helping some of those apprentices with transportation, education, child care costs. So again, that partnership and having that connection with all the partners coming together to support that ComforCare. Penny Byrne is an assisted living center located at High Point, and they were not the first. They were one of the first in the state to partner with the North Carolina Department of Public Instruction and hire a high school student that was CNA certified, and again, taking advantage of the tuition, the state tuition waiver. And they also recognized that they wanted to, and I'm sorry, I think I'm using some of your words, upskilling, reskilling, some of their incumbent employees. And so they also enrolled those into the apprenticeship program. So the high school student is on track to earn her RN. And the two incumbent employees, one is LPN and one is RN. So they are working the program successfully. That's going
Right. So there are applications here. I do want to say that apprenticeship model coming into healthcare, then a little bit of a round peg and a square hole. Is that fair? Holly, you want to share some experiences maybe there of, okay, we had to overcome this. You already talked about the nomenclature, the jargon that we have to use. So
I think one of the other issues we run into is the workforce is overwhelmed in general. Nurse managers, floor managers, administration in hospitals. And to have that time to pause and process and sit down and understand exactly how this applies, I think takes attention. And in this fast-paced environment of healthcare, and they're literally trying to put Band-Aids on arterial bleeds and trying to, stop the flow. I think that's definitely one of the challenges, is just kind of getting them and saying, listen, no, this is really going to help you, I promise. You just have to think a little differently than you have in the past. That's one thing. But I'll tell you, if we're looking at retention, like I said, 100%, and I'm a quantitative researcher, I'm an epidemiologist, but I have to pull in some qualitative components to this. The students and the feedback that we're hearing 2 years post graduation have been working now at that same small community hospital, serving the community in which they live. They're telling me, as a teacher, you're at the stage on the stage, listen to what I say, everything you need to memorize, and, I'm really important. And these concepts are really important, right? But hearing it from your faculty is one thing, but seeing it in the hospital and seeing it, that really helps support and reinforces what you teach in the classroom. The support that they get not only from the hospital and their mentor, and they can go to their mentor and be like, oh my God, my teacher, she tried to tell me like she's the most important thing in the world. Like having that stress relief and that support person, not only at the hospital or at the place of employment, but also at the college. It's these qualitative components that are encouraging and keeping people where they are. So I think that's another one of the surprising things that we found when we kind of came back and said, hey, you did this. Tell me about it. Tell me the truth. And how can we improve, right? But the other thing is that the apprenticeships are so contextualizable. Right? It is really, literally the framework. And you can build a house however you want to build it. You can build it big, you can build it small. You can take one apprentice, you can take 100 apprentices. So the idea that the flexibility of it, and the employer, I have found, at least from the employers I've talked to, I'm not an employer, but they haven't really changed anything they've done. Right? If you're going to be doing all of these same things, it's just, again, call it something slightly different.
Well, and from the employer standpoint, you've got an extra set of eyes and an extra set of hands for those people who can deliver care. And even in SNAP 1, those individuals who are only answering the phones, being supportive, getting supplies, watching the staff work, that's an incredible experience because it doesn't exist anymore. We just don't have it. Our kids don't have it. Okay. Any last words from the panelists? Any missions or blessings, as I was told way back when I was young?
I would just say, for apprenticeship programs, just know that as a healthcare provider, you are already doing the work. You've already got the related education, you've already got the on-the-job training, and progressive wages. What we can add to your program are credentials and just supporting you along the way and identifying that talent pipeline to support you with your needs. So give me a call.
I guess the biggest take-home message is it's definitely worth an effort, even long-term care, public, private, it doesn't matter, a large hospital, a small community pharmacy. Our students will have a job. Why not with you? And why not continue to support them so that they will stay with you? And I think that's the big thing to remember is that these students will work. They have to. So just let's try and help them to stay with you after they're done with us to build up retention.
Michael?
Yes, I would say for those that are here that are with healthcare systems, that creating those opportunities, collaborating with across the spectrum within your healthcare system to find ways where apprenticeships can function is the key to kind of filling those voids and creating those pipelines that will bring in that continuous workflow that you need for those operations. So create those opportunities, and I think the people will come with the results.
All right. So I'm going to do something different. I'm not going to ask them questions because these people will be here and I'm forcing you to talk to them if you have a question. That's how we learn. So I do want to leave with one thing. The word collaboration is an amazing word. I'm all about everyone's lexicon. What's the second portion of that word? Labor. Nothing's going to happen unless you work at it and you create it. So collaboration is an important word, but know that it requires the work. Thank you all so much. Thank you for what you're doing.
I just want to thank the panel again and allow them to get a panel. Also, can Stern, could you get Warren in the picture too? I'm sorry. I apologize to you all.
Let's stay. All right. Before we go forward, all right. Thank you, Stern.
So I just want to thank you all for staying with us. That was a very insightful panel discussion. There were some consistent themes around retention, and this is all great content that will move us forward. So we came up with some unique, innovative ideas from the third annual Healthcare Workforce Summit, and I already have another idea for how we might really take the opportunity to benefit from this dialogue on today. So my call to action to you is to be responsive to an invitation for a working meeting. With this particular meeting, what I'd like to do is take some of the resounding themes and really hear what we might be able to come up with in the way of strategies, particularly with regards to some of the opportunities that might be able to address retention and then wage gaps. These are not questions that can be resolved immediately, but we certainly need to begin to form some kind of guide or pathway that will connect all of us together. And I do believe the answers, or at least some of them, are in the room. I don't think you all would disagree with that. So I just want to thank you all again. Please give yourselves a round of applause for being here. And that was my call to action. But I'm going to have the final closing remarks and salutations, and I'm going to render the floor to Fred Hendrick, who is the Assistant Director of External Affairs for GuilfordWorks. He has over 25 years of experience in workforce development. Fred.
Thanks, Joe's called me out. All right, so this is a great event. Just want to thank the esteemed panelists, speakers, and guests, and special thanks to UNCG's School of Health and Human Sciences for hosting. So this is a great location. This is my first time in this building, so it's great. But also, just kind of sticking with the theme, and even before we get to the theme, I want to give a special shout out and thank you to Joe for leadership and the team in bringing this together. So one of my first things, I guess, we look at as the first step is really collaboration and that partnership as we build this workforce. I think the next step is really being intentional as far as doing the community outreach for communities who may not know these opportunities. When we look at healthcare, healthcare and the social assistance is the #1 sector in Guilford County and the Piedmont Triad. We have over 114,000 individuals working in the Triad area in healthcare. But if we look at a decade and project these openings a year from now, we have over 126,000 individuals, these opportunities to fill positions due to retirements, but also turnover. So there's an opportunity for this group to really build the #1 workforce in the Triad area, but also the nation. So let's take this time now to work over the course of the year, and next year this time let's report out some of the measurable gains. Thank you again. Also want to thank you on behalf of the board and Executive Director Dr. Danielle Harrison, and we look forward to seeing you next year. Thank you.